Is
Good
already
morning,
3
Dr.
minutes.
Ashok.
Anji sir, good morning.
Good morning.
Please start in 3, 2, 1. Please start, sir.
Yeah. Good morning to this another episode of PG Clinic organized by FOGSI ICOG every second Sunday of the month at 11:30 a.m. At the outset, we are thankful to FOGSI President Dr. Jaideep Tank, FOGSI Chairperson Dr. Parul Kodawala, FOGSI ICOG Vice Chair Dr. Sheila Mane, Dr. Parag Biniwala, and all our ICOG Governing Council members, and Dr. Madhuri Patel, our Secretary General FOGSI. With all your support, we are running this program for last 2.5 to 3 years, continuously every month. And this time, we have changed few of the formatting of the program. Earlier, we used to have case discussions only. Now we are having in the start of the program, the doll and dummy and demonstration of various practical maneuvers of labor. Then we have one case discussion, and then we have a how to do it series where we try to give some skill enhancement training to our students. So with this format, I am also grateful to my colleague, Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, who are with me in organizing this program for a long time. And with all your blessing and blessing of FOGSI ICOG, we are able to do this program successfully over last many years. So I welcome in today's program all my expert faculty and chairpersons. Today we have Dr. Roop Maji, and in our faculty we have Dr. Ashish, Dr. Prasanna, Dr. Sobha Gudi madam, and we are hoping that Dr. Parul and Dr. Parag will join. Dr. Parag is with me in Delhi. He's on the dais at the moment in a program, and let's hope he will join soon. And without further delay, I welcome Dr. Sheila Mane madam also, who has spared her valuable time to join us in the morning of this Sunday. I request Dr. Sheila Mane madam to say a few words.
Yeah, good morning. Should join, and also the students, those who are present, as well as Dr. Ashish. I'm very happy to see that this series is so popular, and we are conducting it every month. And I also see that all newcomers like Prasanna had joined today, and as Dr. Ashok said, that we would like to see her association henceforth again many times. So it's nice that we are able to connect to so many teachers and faculties in medical colleges through this, and the students are also getting the exposure to different teachers, so that they really get well prepared for their exam. And the program is nicely divided, and I think we have stalwarts like Arup Maji, who is going to talk about the transfer slide today, then the case discussion, and I think we also have Dr. Hara Patnaik, I think, who is going to give some tips and tricks. So I welcome everybody. Dr. Shobha Gudi, Dr. Meena Saman, Dr. Prasanna, I think will be joining, or they must have joined. And very happy to see that this program is gaining more and more popularity. So thank you, Hafizur, for your constant, I think, dedication towards this program, as well as Dr. Ashok and Dr. Ashish. So all the best, and I think we can start with the program now. Thank you.
Thank you, madam, for your encouraging words. And we are also grateful to Dr. Meena Samant and her institute, and she has kindly consented to be a part of today, and her students are presenting the case today. So thank you, madam, for supporting ICOG. And with these words, I just want to inform our audience that this program is also being recorded, and all the recordings of this program and all the previous recordings are available on the ICOG website. And you are most welcome to visit the ICOG website and take advantage of these recordings. And I take this opportunity also to inform you that application for fellowship of ICOG are available online now, and you have the advantage of getting your fellowship in next AICOG in Mumbai, which is at Geo Center, and you can very well apply for ICOG website. ICOG fellowship, these are available online. You just visit the ICOG website, and there you have to just fill the application form online, and it is very simple and very easy to apply for ICOG fellowship, and even the junior person can apply for the membership of the ICOG also. So please take advantage and try to be come in the fold of ICOG to be and become a member or fellow of ICOG. Now, with these words, I express my sincere gratitude and thanks once again to all our FOGSI office bearers and ICOG office bearers and my colleagues, Hafiz and Ashish. And I now invite Dr. Ashish Mukhopadhyay sir to say a few words, and then to Dr. Hafizur Rahman to start the program.
Thank you, Dr. Ashok Kumar, and it's a pleasant morning for all of us. Yes, I think the details of the program and the evolution of the ICOG program has been explained to you. Last 3 years, we have been constantly doing that. Initially, we started as a case discussion only. We used to take 2 cases and their discussion. Now we have evolved and branched into the NMC format, that is the lecture class followed by demonstration and students' case presentation. So this is the way we're evolving, and we also invite suggestions from our learned faculty members, whosoever is involved and interested in PG teaching. Coming back to the topic today, yes, obstetrics is our passion. While you are in the students, not so much a passion, but it's a necessity for passing the exam as well. So I think that we have taken up this model, that malpresentation, like face presentation, brow presentation, the transverse lie, and the related topics will be discussed in detail. Plus, along with that, we'll have a gynae topic also by Dr. Harar Prasad Pattanayak. So I think that the format is well set, and I believe that all the learners will be benefited through this, this type of interactive. And remember, this is an interactive program, so always throw your questions at the chat box. We'll take them up at the end. So with those words, I think I will request Dr. Hafizur to start the program, and also remind you, as Dr. Ashok Kumar said, all the recordings of this program as well as the previous programs, and in future also, will be available in ICOG website. So whosoever is your friend who couldn't attend this program, kindly tell him or her to go back to the ICOG website. That will increase the footfall at the ICOG website also, and you'll be able to be aware of what has happened in last month or last maybe 1 year. So thank you very much, all the faculty members, the organizers, the President FOGSI, and the Chairman ICOG, and the Vice Chairman and Secretary General. So I'd like to request Dr. Hafizur Rahman to start the program. Hafizur.
Yeah. Good morning, everyone. Thank you so much, Ashok sir and Ashish sir. As sir, Ashok sir and Ashish sir told, we are thankful that is the FOGSI as well as ICOG, the office bearers, has given us this opportunity to conduct this program. And I would like to just mention briefly that we started this program in July 2021. So we have just completed 3 years. And we have come out every month with a program changing the topic as well as the college institution, so that the different college students as well as the faculties gets an opportunity. So without wasting much time, I would like to start the program. And we know that is the students many times and they face difficulty in face, brow, and transverse lie. So this was our, after we discussed, and we decided that this topic we should go on. So for the first topic, that is none other than Professor A.K. Mazi. Sir is at present and Professor Santiniketan Medical College, Bolpur, West Bengal. And sir was associated all throughout, including RG Khan Medical College, and he has been author of several books. So he's a very renowned academician on this. So sir will be doing face and brow presentation, and as it was, we were giving more importance on demonstrating the things, and sir will be doing that, which I'm sure will be greatly beneficial to the students. Followed by, we will have the students from Kurzi Holy Family Hospital, Patna, and Meena Samant Madam students, that is Dr. Ruparani and Dr. Dipti Mai Pati. So they will have the case discussion on a transverse lie, and I would like to invite everyone, especially Mazi sir and all other faculties, including Ashish sir. So for this program, and Shobha Gudi madam is always there for in often, and we have madam with there. And along with that, we have Dr. Pragya Mishra Chaudhary madam and Dr. Z. Prasanna for this program. So we always keep gynecology or one of the other topics so that student gets versed with that. So this month we have steps of vaginal hysterectomy, and Dr. Haraprasad Patnaik sir will join very soon for this, giving tips and tricks for doing this procedure, which is very much essential and in future also. So I'll not have much time, so I'd like to request to start Professor A.K. Mazi sir to start his demonstration and as well as in presentations. And I request the students to be carefully observe, sir, for this.
Before Dr. Maji starts, I'd like to request Dr. Prasanna, Dr. Shobha Gudi, Dr. Meena Samant to kindly rename yourselves, because your name is still visible as speaker. We know that you are all excellent speakers, but we need to remind you that we need to remember, rename you also at this time.
So, yes, sir. We have 5 people who are showing speaker. Please rename yourself. Sir, Parag Binyala sir has also
said. Also. Sir, kindly
Parag
rename.
Sir.
Yeah.
Parag sir, welcome, sir.
Thank you, Officer.
Sir, we'd like to say any few word for encouraging for the students.
I'll just say thank you to all the examiners who've joined. I can see my governing council members also here. I'm attending one of the conferences out here, but then I could not resist. I finished my lecture, so I could not resist to join this program. Must appreciate efforts by Dr. Ashok, Dr. Ashish, and Dr. Hafizur, who've been consistently carrying out this particular activity for last 2.5 years. And there's additional responsibility for 1.5 hours, which you need to continue. And then, of course, we'll take it little ahead from this. So thank you very much and enjoy the learning.
Thank you, Dr. Parag.
Thank you so much. Maji sir, over to you, sir.
Good morning, everybody. Good morning, Dr. Hafizur, Dr. ICOG, all the office bearers who are present there. I am not wasting any time. And so directly to the subject, the very interesting subject, face and brow, but this is less taught by our teachers. So I'll start first with the demonstration with the fetus pelvis and dummy fetus pelvis skull, and then we'll show all the things in the PowerPoint and small video, which is a very rare video, but it's a very long back. That video I had done, I will show for the benefit of the students so that they can understand. And so just I'm setting. Ashish, you tell me whether I am visible or not. Ashish. Hello.
You are visible and you are audible also.
Okay. Now, dear beloved postgraduates who are here, you see this is the fetal head. Dr. Shobha, please mute yourself. Dr. Shobha, please mute yourself. You see the fetal head. There, see the fetal head. And fetal head, first I'll go to the different areas. First we'll go to the different areas. You see the area, the face and brow, which one is the face and which one is the brow, and which was in the vertex in short. The face is, the boundary of the face is, you see, this is the supraorbital ridges, this is the supraorbital ridges and the face, and it is the submentum, that is the junction of the floor of the mouth and the neck. That is, you can see well, This is the area. No, this is the area actually. And this is the junction, not the mentum. Always remember, that is very common mistake, that it is the junction of the floor of the mouth and the neck, and the other boundary is the supraorbital ridges and the root of the nose. And the area of the brow is the area of the brow, root of the nose and the supraorbital ridges, and the anterior frontal bregma and the coronal suture. And parietal, the vertex presentation, all of you know, it is the quadrilateral area. In front, there is the anterior fontanelle, and behind is the posterior fontanelle lambda, and laterally the two arbitrary lines. You can see two arbitrary lines, one here and another is here, the parietal eminences. So I am not going into detail other things. And about the diameter, that is the important diameter. What diameter is the key? When the important diameter is the in completely flexed vertex. In the completely flexed vertex, the diameter is a sub-occiputobregmatic. Sub-occiputobregmatic below the occiput to the anterior fontanelle, which is 9.5 centimeter. The completely flexed vertex. And incompletely flexed vertex, sub-occiputofrontal, that is the in front of the anterior end of the anterior fontanelle, or that is the middle of the sinciput. That is also the 11 centimeter. And another thing is next, when it is done, just like after the flexion, and we going to the extension, the diameter will be the mento-vertical. That is the mento-vertical. From the mentum to the highest point of the sagittal suture. That is the mento-vertical, which is actually the 14 centimeter. It is the mento-vertical, the partial extension. And in between that, there is a diameter, that is the occiputofrontal, from the occiput to the frontal, root of the occiput to the root of the nose. This is at the deflexed vertex. It is 11.5 centimeter. And after the partial extension, if there are more extensions occur, what will happen? More extension, there is a diameter. The diameter will come. That is the submento-vertical. That is from the mentum. That is a junction up to the highest point of the sagittal suture, 11.5 centimeter. That is incomplete extension. And in case of complete extension, diameter is the submentum. That is the junction of the floor of the mouth and the neck up to the bregma. That is also 9.5 centimeter. Like the occiputo anterior vertex presentation, the same diameter. But what happens is that if you go to the transverse diameter in case of face is the bitemporal diameter. That is the end of the coronal suture. One is the end of the coronal suture here, and one of the end of the coronal suture here. And this is 8 centimeter. And the maximum transverse diameter is the biparallel diameter, which is 9.5 centimeter. So when the faces pass first, that is the subocciputobregmatic completely extended, and also the bitemporal diameter, the maximum diameter, biparallel diameter lies far behind, from here to here. That is almost 7 centimeter. That is why it is the abnormal labor and takes a long time. So this is about the fetus. Now we come to the directly go to the with the pelvis. So you go to the pelvis. First you hold the pelvis in anatomical position. That is the basic thing you have already seen. So the anterior super relaxed spine, symphysis pubis is the same coronal plane, and the plane of inlet will make an angle of the 50 degree with the floor. So always is that, and always try to hold the pelvis in a one hand, particularly the left hand, because your other hand will be used for showing the demonstration of the mechanism of the labor. And about the pelvis, the diameters which are important, not related to all the face and face and the brow, but the anteroposterior diameter, you know that 2 conjugate from the sacral promontory, the superior surface of the symphysis pubis, and another the obstetric conjugate of the sacral promontory to the posterior surface of the symphysis pubis, most prominent point in the midline. That is the obstetric conjugate, 10 centimeter, and diagonal conjugate that can be measured clinically by the so the vagina from the sacral promontory to lower border of the symphysis pubis, that is 12 centimeter. And regarding the oblique diameter, that is very important also, that is here also. That is the oblique diameter, right diameter, the right sacroiliac joint with respect to the sacroiliac joint from the iliopubic eminence, it is 12 centimeter. It is 12 centimeter. And the transverse diameter, it is the transverse anatomical transverse is actually the 13 centimeter, the transverse furthest apart point of the pelvis, for the furthest apart point of the inlet, that is the iliopectoral line. And the obstetric transverse is actually the midpoint of the true conjugate or the anatomical conjugate, which passes transversely. So this is about the all and the. But you see, there is no diameter here, which is the in brow presentation, that is the mento-vertical 14 centimeter, cannot cross any diameter. There is no diameter. So in case of persistent brow presentation, where the diameter is 14 centimeter, if it's persistent, and there no vaginal delivery is possible. So with this, I am directly goes to the face mechanism of the face. You see here, in the face presentation, I have said this is the face area of the face from the submentum to the, that is the neck joint and the supraorbital ridges. And first, what are the different position of the face? What are the different position? Positions mean it is the relation of the different quadrant of the pelvis. Now, left mento anterior, you see, it is the left mento anterior, mentum toward the left iliopubic eminence, and right mento anterior, mentum towards the right iliopubic eminence, and the right mento posterior is the right sacroiliac joint. Mentum is the, you shall see the mentum is the right sacroiliac joint, mentum here, and left mento posterior, that is the left sacroiliac joint. So again, I am repeating, there are the 4 positions. One is the showing left LMA, left mento anterior, RMA, right mento anterior, RMP, the right mento posterior, and last is the LMP, left mento posterior. This is the face presentation. There are only 4 positions are considered in case of face. But one important thing you must know how to remember. This is very difficult. But you go to the occiputal anterior position. This is very, listen, there's postgraduates, please listen this thing. How will you remember the position of the face? Now, suppose the left occiputal anterior, it is the completely flexed left occiputal anterior. If you make it, left occiputal anterior, you make it extended, what will be it? That is the right mento posterior. This is the right mento posterior. And if is the right occiputal anterior, if you make it extended, it will be the left mento posterior. And in case of right occiputal anterior, right occiputal posterior, if you extend it, it will be the LMA. And in case of left occiputal posterior, it will be RAMA. You make it extend, it will be right MA. So that is the important points and tips to remember. How to remember? There are 4 positions. Here, RMP is considered the first. Second is the LMP. Third is the RMA, and fourth is the LMA. So this is the 4 positions of the face presentation. Now the mechanism. As the mechanism of labor, here the cardinal, that is the cardinal feature. The cardinal points are same. It is the first is the engagement, then is the descent, engagement, then is the descent, and here instead of flexion, the extensions occur. Suppose in LMA, what LMA, and always say in case of for mechanism, lie is longitudinal, attitude is in flexion, extension, attitude is in extension. In phase, attitude is in extension, not the flexion. And then descents occur, more descents occur, and more extensions occur for incomplete to complete extension, and then internal rotation occur. During the internal rotation, what happens? There is the twisting of the neck, and the head is delivered by, first you see the submentum hinges under the symphysis pubis, stems under the symphysis pubis, and first delivery is the face, and then the then the brow, and lastly in the occiput. So this is the movement. So first the submentum stems under the symphysis pubis. You can see the symphysis pubis, and the face is delivered by, whole thing is delivered by the flexor, and the first is the face is delivered, then the brow is delivered, then the subocciput is delivered. You see here during the delivery, the diameter which is coming in the vulva, that is the submento vertical maximum diameter, submento vertical, that is the 11.5 centimeter. So diameter of emergence in the vulva is more, so there is a more chance of complete perineal tear. Now what is the next? Next is the, as there is the twisting of the neck, so there will be the at the twisting of the neck, so there will be, what will happen? There is the restitution, and after that there will be the external rotation, and external rotation for the internal rotation of the shoulder. I am showing in the dummy picture. So just repeating, lie is the longitudinal, and anteroposterior diameter is the subocciput, submentobregmatic, engages in the right oblique diameter, and descent, extension, internal rotation, so twisting of the neck, and the head is delivered, and the face is delivered, and as you see the submentum stems under the face is delivered, followed by the delivery of the brow, followed by the delivery of the occiput, and then internal rotations occur. That is that then the restitutions occur, not internal rotation. So to untwist the shoulder, and for external, after the external rotation occurs, so the internal rotation of the shoulder. So this, and then the it is thus like this, the normal delivery. In case of shoulders are delivered, and trunk is delivered, by lateral flexion. So this is all about the mento anterior. But what about the mento posterior? You see, for mento posterior, suppose there is a RMP, right mento posterior. In mento posterior is the incomplete extension. That is the submento vertical. The diameter is 11.5 centimeter. Submento vertical. It engages in the right oblique diameter, and the descents occur, more extension occur. But here, in contrast to the occipital anterior, the internal rotation does not occur in 80% cases. Here only occur in 25 to 30%, even less. So after complete extension, it becomes LMA by 3/8 rotation. And in the meantime, the shoulder, also cannot twist the 3/8. So 2/8 rotation occurs of the shoulder. And the rest of the mechanism is like the mento anterior position. This is about the mento posterior. But what about the rest of the cases? 70 to 80% cases. What happened? You see, what happened in the rest of the cases, depending upon the degree of the extension. What happened? There may be it may stay here persistently, that the right oblique mento oblique diameter arrest occurs, and it may slight anterior rotation, so arrest occurs, in the transverse position, TMA position, and it may comes behind also. That is the left, that is the direct sacramental arrest. So these are the three fates. If the arrest occurs in three conditions, the arrest occurs. So there is no mechanism of the labor, because the manual rotation is very difficult in these cases. So what will happen if there is no such face-to-face delivery? There is no face-to-face. Whatever happens, you can see the mento posterior. With the mento posterior, you see this is the mento posterior, and mento posterior. So direct mental arrest, direct mental arrest. That is the mentosacral arrest. And what will happen? The face is what will happen? That will be like this. That will be like this. That is the sternobregmatico diameter, sternobregma and up to the sternum. That diameter, that sternobregmatico diameter, which is 18 centimeter, and the chest telescopes in the sacrum, and there is no delivery other than the cesarean section. So that is the important difference between the occipito-posterior position, that the face-to-face delivery occur. And one important thing is that difference between the mechanism, that in occipito-posterior, what happens face-to-face delivery, the root of the nose hinges under the symphysis pubis, and root of the nose hinges under the symphysis pubis, and the head is delivered by flexion. Head is delivered by flexion. You can see the flexion, that is the brow and occiput, and the face is delivered. In the face is delivered by extension. But here already there is extended. So that is the basic difference between the face-to-face delivery and face delivery. In face delivery, the submentum seems under the symphysis pubis, but face-to-face delivery, the root of the nose seems under the symphysis pubis. And in face-to-face delivery, first the flexion occurs to deliver the brow and then extension occurs. But here, already there is extended condition, and head is delivered by flexion. So with this thing, I am going to share the screen. You will just quickly go to the PowerPoint. You will see in my PowerPoint. You can see. And during the forceps delivery, you see one thing I am showing with the dummy fetus pelvis. During the forceps delivery, as you can see, as the forceps delivery, you just remember the mechanism of labor. Already there is the submentum hinges under the symphysis pubis. So you give traction first downwards with the forceps, traction downward, and the rest of the head is delivered by flexion. So during forceps delivery, if the head is like this, you just give the traction by the forceps, and so that it stems under the symphysis pubis, and then forwards and upward the head will be delivered. This is the mechanism. And no ventouse is possible, but because it will injure the particular eyeball, face and eyeball, and there is no good application. So I am next go to the PowerPoint presentation. PowerPoint, you go to the because I am sharing the screen. Sharing the screen. Is it visible? Is it visible? Hello?
Yes, sir, it's visible.
Is it visible? So it's the face and bow presentation. Dr. Meena, good morning. So in the face and bow presentation has been allotted to me. The incidence of face and bow presentation is very low. Brow is more lesser than the face presentation, is 1 in 500 and 1 in 1000. And area of the face, you can see the area of the face. I am showing the pointer options. That is the laser point. Laser point. The area of the face is the bounded by the root of the nose, up to the junction of the floor of the mouth and neck of the neck and the neck. So that is the area of the supraorbital ridges and the supraorbital ridges on side and junction of the floor of the mouth and the neck on other side. And area of the brow, it is bounded by the root of the nose and supraorbital ridges and the anterior fontanelle and coronal suture. This corresponds to the sinciput. It corresponds to the sinciput. So this is the area of the brow, from hair to hair. That is the area of the brow. And face from root of the nose and supraorbital ridge to the junction. Here neck is not visible. Here the neck is not visible. Here it will be the and this is the, you can see very well here. And when the mouth is that is the mentum is palpable. Mentum is palpable. It is the face presentation. Face presentation is not the brow. The face presentation, not the mouth. That is the differentiating feature. You may get eyeball in both cases. And now the face, you can see the extended face. Head is in extension, complete extension. And then here there is the angle, spine and head. Angle is very narrow. That is in between flexion and extension. That is the partial extension. That is the brow presentation. All the pictures, all the photographs, all the book or my own collection, there is no photograph or pictures has been taken from anywhere either. And now you come to these things, the area of the brow from this to this, and area of the face from this to this. So this is simple, that is simple things. And now come to that is the vertex, brow, and this is the sinciput, occiput, and this is the area of the face. And now come to the etiology. It is very theoretical. Majority of the cases of the contracted pelvis, the 40% cases, multiparity is an important factor. Obliquity of the uterus is the defects in the passenger. The congenital malformation is the most important. That is the one is the anencephaly, and any swelling in the neck. Actually, there any swelling that causes the extension of the anterior surface of the neck. Any swelling, congenital goiter, any swelling or congenital tumor, and cord around the neck and abdominal tone of the extension of the neck. Now, diagnosis of the face presentation mostly found in the multiparita, mostly diagnosed during labor, very rarely in the antenatal period, during the antenatal period. And abdominal examination, if you see the abdominal examination and vaginal examination and imaging, there's three things. Abdominal examination can be done and you can make an idea. The fundal give is the soft, broad, podalic and is palpable. Lateral give, the mentro-anterior fetal links are filled anteriorly and fetal back is palpable, flanks with difficulty. A groove is felt between the occiput, between the occiput of the in the spine. In mentro-posterior position, the back is felt in front of the abdomen. Pelvic grip, that is actually the third and fourth leopold. Head is high in position, and the delayed engagement. Cephalic provenance is the occipital protuberance. Here, cephalic presentation. Cephalic prominence is the occipital position. In contrast to the occipital anterior, there the prominence is the sinciput, because in the flexed attitude, the sinciput will be well palpable for abdomen. Auscultation fetal is distinctly to the side of the limb. Now, vaginal examination. In early labor, elongated bag of the membranes with higher presentation. Following rupture of membranes, face is identified by the presence of mouth with hard alveolar margins, alveolar margins, and nose, malar eminences, and supraorbital ridges, and eyeball and chin. In mentro-anterior position, chin is palpated anteriorly. Anteriorly, chin is palpated. In late labor, due to formation of the excess edema, it is difficult to differentiate between the face and beach presentation. And differentiation between the face and beach presentation is very important point for the postgraduates. One is the three points, the two malar eminences, and the mentum lies in a triangle. Malar eminences and the lies in a triangle. Is a triangle. You can see here. Actually is a triangle. Two malar eminences and the mentum is a triangle. And whereas in case of beach presentation, the anal canal and the distal tuberosity and the sacrum lies in the almost in the straight line, and the finger is not stained and meconium stained. In case of face presentation, beach presentation, there may be meconium stain. Now, role of the ultrasound, definitely there is a role of the ultrasound, transabdominal ultrasound. There is a sharp angle between the cervical spine and the occiput in transabdominal. To exclude any congenital anomaly, always you see because it is associated with the congenital, to note the size of the baby. Outcome of the labor in face presentation, maternal prognosis, labor becomes prolonged due to the ill fittings of the face over the lower recurrent segment and cervix in slow dilation of the cervix, early rupture of the membrane. Molding is absent in face presentation. In mento-posterior position, long internal rotation is needed. In persistent mento-posterior position, no mechanism like the occiputo-posterior position. I have already explained, and hence there is very big chance of obstructed labor and sequelae. More chance of operative delivery. Now, fetal prognosis. Face becomes edematous and traumatized due to repeated palpation. As you can see, the face becomes repeated palpation. What happens to the face? Fetal asphyxia occurs. Even if it is a prolonged death may occur. That is the monitoring of face vaginal delivery. CTG monitoring is mandatory, and the vaginal face delivery. More operative delivery, its consequences, more chance of congenital anomaly. To assess the pelvis and evaluate whether vaginal delivery is possible or not, or the how to manage, whether you because the majority of the cases, 40% cases contracted pelvis. So do the pelvic examination, whether vaginal delivery is not. If the pelvis is inadequate and there are other complications, obstetric complications, go to directly to the cesarean section. Now, always exclude the fetal malformation in the fetal presentation. Explain the patient relatives. The mode of delivery depends on the position of the face, whether it is the mento-anterior position or the mento-posterior position. In mento-posterior, the vaginal delivery through the vaginal route is very difficult and not favorable. Now, mento-anterior, you see, the first stage is managed. The first stage is managed as usual by keeping in mind that labor may be prolonged. In second stage, spontaneous delivery is awaited. Give a liberal episiotomy. Chance of CPT is as occipital stretches the subconium, and diameter is the larger, that is the submento vertical 11.5 centimeter. But in case of occipito anterior, it is only the 10 centimeter, that is the suboccipito frontal, but here is the submento vertical. A delayed second stage forceps delivery is performed. When to this contraindicated. Forceps delivery, I have already showed how the submentum hunges under the symphysis pubis. Downward traction to submentum brings under the symphysis pubis. Then you get the upward and forward movement. The face is slowly extracted with the nose, eye, brow, and the occiput appearing in the pelvis. But always remember there will be chance of complete penetration. Now, mento-posterior. Vaginal delivery is attempted fast by giving a reasonable period of time and for internal rotation of the mentum, because 20 to 25% cases the long internal rotations occurs. Long internal rotations occur with the prolonged labor. And anterior rotation of the once completed, spontaneous delivery for forceps delivery can be done after the rotation. In non-rotation or malrotation, cesarean section is safer. Manual rotation in a posterior chin to mentum anterior is dangerous, is usually not recommended, and it has been given and it is everybody recommends us not to do the manual rotation in the mento-posterior. In obstructed labor, like persistent mento-posterior position, cesarean section is performed. That is an important question for the postgraduate. In both vertex and face presentation, the anteroposterior diameter is 9 face of the. Why the face is abnormal? Just quickly go through. Ill fittings of the area of the uneven face are also responsible for delayed progress, early rupture of movements, and delayed dilation of the surface. So for long labor, there is a more chance of confluence. There is a space. There is a space side of the face. In face presentation, the larger biparietal diameter fetal head lies more behind the anteroposterior diameter, whereas in vertex presentation, biparietal diameter lies in the same plane of the anteroposterior diameter. In face presentation, the diameter is the submento-bregmatic and bitemporal, but biparietal diameter lies far behind, about 7 centimeter. So maximum large diameter lies behind, that is the prolonged liver. The chance of perineal tear is 4. I have already explained, and PPA is also more. Now brow presentation. The area of the brow bounded by the supraorbital ridges one side, anterior frontal is the other side. And so this is in the partial extension, in between the extension and the flexion. And denominator is frontal eminence diameter of which is the mento vertical 14 centimeter. There is no diameter. There is no diameter in the pelvis. That is the 14 centimeter. So brow persistent but vaginal delivery is not possible. Both primary and secondary brow are possible. Now, the similar to the face presentation, brow is unstable presentation, which may convert either to face or vertex presentation during labor. Overall, about 1/3, a little less than 1/3 of brow presentation that can be done vaginal delivery only by the conversion, spontaneous conversion, not the manual. Now, diagnosis. Diagnosis para-abdominal is very difficult, only the head is big. But here, the supraorbital ridges, forehead and anterior frontal palpable. Mentum is not palpable. That is the difference between the face and brow. If the mentum is palpable, that is the face presentation. If mouth is palpable, it is also face presentation. In both conditions, eyeballs may be palpable, and sonography can give the diagnosis. Outcome. In persistent brow presentation, obstructed labor and ruptured uterus in multiple are the outcome. If not diagnosed and not attended in time. On few occasions, brow may be converted to face and vertex presentation favoring vaginal delivery. Fetal pregnancy, chance of birth. Management of the brow when in labor with a living healthy average size baby, vaginal delivery is not possible. So cesarean section is the best method of management. However, congenital anomaly of the fetus should always be excluded in case of face and brow. When the pelvis is good, the size of the baby is about the brow may convert into itself face or what in the 40% cases of the during labor. So there is a possible intelligent expectancy in this case of spontaneous delivery may occur in case of brow presentation. In antenatal period, there is chance of spontaneous conversion to face or brow. Earlier methods of conversion under anesthesia, mento anterior brow to mento anterior face by extension, or mento posterior or anterior to anterior vertex by flexion are not practiced nowadays, as cesarean section is more safer method. And so in brow presentation in healthy mature fetus with persistent brow presentation, there is no mechanism for delivery through the vaginal route. Now mechanism of labor in face presentation, I will show the illustration. You show the illustration. You see, in case of brow presentation, a face presentation, the diameter is submento-bregmatic. Submento is 9.5 centimeter. In brow, it is the mento vertical, which is 14 centimeter. I am not going to the other. And here is the complete extension. In case of brow, it is the partial extension. Partial extension. Now, 4 position. The first position is regarded. RMP is regarded as the first position. LMP is regarded as the second position, and third position is the left mento anterior, and right mento anterior is the fourth position. Now, that is the important point I want to stress during the demonstration. Left occipital, just put the left occipital intervista, first position of the vertex. Following extension, it becomes the right mento posterior. And right occipital anterior, following extension, it becomes the right mento posterior. And right occipital position, the third position of the vertex, third position of the vertex, the following extension becomes the LME. So LOA becomes the RMP, ROA becomes the LMP, and LOP becomes the RME. And LME is the commonest. Definitely LME is the commonest. Now, cardinal movements, I have already said, engagement, descent, extension, internal rotation, flexion of the delivery of the head, restitution, and external rotation. Only difference from the occipital anterior, here is the instead of flexion, there is the internal, there is the flexion. Instead of extension, flexion, here is the extension. You see, engaging anteroposterior diameter, here is the suboccipitobregmatic, fully extended head, and submentopedaling incomplete. The diameter of engagement of the pelvis is the roughly oblique diameter, and the mentum counts in relation to the one iliopubic gemina. The anteroposterior diameter, the transverse diameter, do not lie in the same plane in face presentation, and bipartite diameter lie far behind. That is the delayed engagement occur. And next is the descent with flexion. More extensions occur with descent till mentum touches the pelvis. Internal rotation of the chin occurs 1/8 of the circle till the mentum comes behind the symphysis pubis and submentum stands under the PV gut. And there is now twisting at of the neck here. The flexion, the head is delivered by flexion. Face, brow, and vertex are born successively. The maximum diameter of emergence is the submentobregmatic diameter. Then restitutions occur to untwist the shoulder. And external rotation, it occurs 1/8 of a circle to the same direction of the restitution. And shoulders are delivered as in vertex position, and rest of the trunk is delivered in the lateral flexion. You can see. So this is the engaging in the you see there. This is the right mentum. The mentum is the right side. Mentum is the right side. Right mentum anterior. And this is the more descent and extensions occur after the engagement. After the engagement, this is the engagement. Then more descent, and more extensions occur. More extension occur. Here you can see more extensions occur. Next is the internal rotation occur when the extension is complete. Internal rotation occurs. The mentum comes in front of the symphysis pubis. And next what happens? Head is delivered by flexion. You can see then gradually the submentum is hinging under the symphysis pubis by flexion. And by flexion, the mentum is faces comes first, then the brow, and later on the occiput descending the perineum. That is the more extension. The face, brow, and descending the occiput descending the perineum. There is a chance of the perineal injury. So you will have to cautious. You will have to give the good episiotomy, and you will be aware if the episiotomy needs larger. You will have to give that, and so that to prevent the complete perineal tear. There are 2 and 3. OSS 2, 3 and 4. Now the restitutions occur. You will see the restitution, the untwisting of the neck. Next the extension, then the external rotation. After the return, external rotation, and then the shoulder is delivered. A shoulder is delivered, the anterior shoulder, and then hinges first, then the posterior shoulder, then completion of the anterior shoulder and posterior shoulder both occurs. Then the rest of the trunk is delivered by lateral flexion. So mechanism of the labor in mentoposterior femoral head engagement either in the right or left oblique diameter of the pelvis. Attitude is incomplete extension or submentovertical. With descent, complete extensions occur only in 20 to 30% cases. In case of complete extension, introduction of the mentor occurs by 3/8 of a circle with simultaneous rotation of the shoulder by the twig. I am not going to repeat it. I have demonstrated you. Now, in 70 to 80% cases, there may be incomplete rotation, null rotation, and the short posterior rotation. If there is a incomplete rotation anteriorly, there will be a transverse mental arrest. And if there is a posterior rotation, there will be no rotation, so there will be a posterior oblique mental arrest. And if there is a short posterior rotation, persistent mental posterior arrest. In this condition, there is no possibility of the vaginal delivery, like face to pubis delivery and occipito-posterior position. In mentoposterior arrest, the chest becomes telescope in the sacral hollow, bringing large bregmatico-sternal diameter or sternobregmatico diameter, what you can say 18 centimeter. I have shown you in demonstration. Just I am repeating it to hammer to brain of the posterior. And now RMP, that is the right mento, that is the right mento posterior. That is the it is seen from the below, definitely the right mento posterior. That is the right mento posterior. And if the mentum lies on that side, that is the left mento posterior. Now, the long internal rotations occur, and that to only 20 to 30% cases, long internal rotation. That is from here to long internal rotations occur and delivered as mento anterior, just like the mento anterior. You can give also the forceps if needed. And arrest occurs, which is this is a beautiful picture. The illustration I have made yesterday night for you with the help of my wife, Dr. Maji, Swapna Maji, that you can see that the posterior oblique mental arrest, here, and transverse mental arrest, and persistent mento-posterior arrest, That is the three arrest occurs in three positions: posterior, oblique, transverse mental, and persistent mento-posterior arrest. And the persistent and mento-posterior arrest, what happens? I have shown you the chest becomes telescope. Chest becomes telescope in the sacral hollow, bringing the brachymatico-sternum diameter, which is 18 centimeter. So vaginal delivery is not possible. Vaginal delivery is not possible. It will be obstructed labor, ultimately rupture uterus, acidosis, ketosis, dehydration, and rupture uterus may occur. So seizure. So before that, we'll have to prevent this type of progress of labor. We'll have to go to the cesarean section. Now I will show you the I'm sorry, just video is not working actually.
Arudha, I request you to go fast because time
I've
is
already completed, Ashish.
Yeah. No, but the video, I think it will be finished by 5-10 minutes, no?
Not 3 minutes. Only to see the 3 minutes video.
Okay.
A very rare video. Right-sided episiotomy is given. Right-sided episiotomy is given. After confirmation of the face presentation, it is the RMA. The face is visible in the perineum in mento-anterior position. Face is visible in the mentum anterior position. And it is a long back. Dr. Pudipto and myself, the ICOG Medical College, the video. A face is visible in the perineum in mentum anterior position. You can see the mentum anteriorly below the symphysis pubis, the submentum neck, and gradually the delivery occurs. The fetal head, there is a head, occiput. There is a chance of perineal tear. So to take care of that, the perineal tear. And gradually, so you can see the fetal, the leaf also, there is the edemata and the multiple gradually descend submentum stins under the symphysis pubis, and repeated pelvic examination, vaginal examination, that causes the also responsible for that edemata. The head is delivered by flexion. And you can see, and it was the right mento anterior. So restitution on the right side, right mento, and again the external rotation on the right side. Restitution to untwist the shoulder and the external rotation. Then the shoulders are delivered one by one. And followed by the rest of the trunk by the lateral flexion. After this, baby took respiration, and also respiration. You can see the baby took respiration and cried also. You can see the movement of the baby. The baby cried also. But we anticipate the asphyxia, so immediate cord clamping. Now the delayed cord clamping is done, and previously there was no tradition to show the even on the chest. Baby is shown and placenta delivered by the control contraction. You see, by the one hand for the symphysis pubis, and gradually the placenta is delivered by the control contraction, and will no complete perineal tear. When examining the muscle, there is every chance of the sphincter. Sphincter is there is no tear, and there is no cervical tear also. The examining the photo is not visible. Ultimately, the episiotomy is repaired. So, and so thank you for patient sharing. I made acknowledgement to do my better half, Dr. Swapnamaji, and all photographs with myself and my books, 2 books. Thank you all. Thank you, Ashish. Thank you all. Thank you for patient sharing.
Thank you,
Any
Arun,
questions?
for
Ashish, any
your
question?
extensive talk come demonstration, come PowerPoint presentation on a very difficult subject of malpresentation, face and brow. And I believe that you have shown every aspect of the mechanism of labor, the progress of labor, the management of labor in 3 steps. You have shown it in the dummy fetus pelvis, then you have gone for a PowerPoint presentation, and finally you have shown the video. So I believe by this time the students' brain will be hammered into all this information and they should not forget. Ideal is to combine these 3 things together, but that's not possible in virtual world. In real life, face-to-face, we can, of course, we can try that. There are just 1 or 3 comments because of this extensive nature of this presentation. There are so many things to grasp into, and it's very difficult to concentrate on one particular aspect. But the basic defect, I believe the students have understood. Basic defects are 2. One is the pelvis, the inadequacy of the pelvis, like the anthropoid type of pelvis, which favors a malposition, not a malpresentation, that is the posterior, and an android type or a flat type of pelvis will accommodate a face type of presentation. But having said that, clinically to diagnose them is very difficult, particularly in labor, early labor, late labor, because how much ever triangles we draw, it is very difficult to pinpoint those areas like the the malar eminences and the facial this thing and the hard alveolar margin. Very difficult to palpate in the labor, particularly for the juniors. So most of the times they say that some soft part is presenting, and they take it for cesarean section. So I think that for a detailed diagnosis of the particular position in face or brow presentation is quite difficult. It is quite difficult for the posterior also, and in brow also, and in face. Anterior face may be a little bit easier to diagnose, but who allows labor to this extent these days? Fortunately, the 2nd stage ultrasound or the even late 1st stage ultrasound has come into play, which perhaps will increase the diagnostic accuracy. I hope so, because the ultrasound is still in the revolving phase. We are very sketchy about the use of ultrasound in labor. So I hope that the use of ultrasound in labor extends and we can diagnose with better accuracy, because clinically it's very difficult to diagnose all these things. The second point I'd like to mention is the second problem with the fetal head. The basic problem with the fetal head is non-flexion of the fetal head. When it is inadequately flexed, then it becomes deflexed, and it gives rise to the occipito-posterior malposition. Whereas when it is completely extended because of the inadequacy of pelvis, it becomes converted into the face presentation. So the full extension is face, and partial extension or the deflection is the occipito-posterior malposition. That is the malposition. Today we have discussed malpresentation. Now, whatever the situation may be, we must take into consideration that the same factor, the pelvic factor, inadequacy, which leads to deflection or extension of the fetal head, will be operable for the adequacy of the pelvis also, because one in the flat type of pelvis or the dolichopelvic type of pelvis or the anthropoid type of pelvis, they are very restricted to enter into, but then after that it becomes easier. So we need to encourage vaginal delivery in some cases, but that selection is very important, and that selection has to be done by a very senior obstetrician. I wonder how many senior obstetricians are now we have in the labor room who will diagnose the difficult positions like face presentation or the malpositions. Now, coming to the arrests, I think these arrests are very rare these days, and the arrests are equivalent with the occipito-posterior, the 3 types of arrests that may happen. The same mechanism, that means the inability of the head to rotate from oblique or transverse to the anterior position. And there is one point of learning for the juniors, that this, whenever you diagnose a malposition or a malpresentation, I think immediately it conveys to the patient party who is waiting outside the labor room. They are keenly waiting for the labor room news. Tell them initially, from the very beginning, that this labor is going to take, if you have taken a decision of vaginal delivery, of course, that you are going to take a long time because of the factors that Arubda has already mentioned, and also the long internal rotation, which takes 3 times longer time than the normal anterior cephalic presentation. So I think these are the areas, because we don't communicate much with the about the labor room patients these days. And the video, I think lastly, the video was the cake, iceberg on the cake, and which I think that it was very nice. Practically seeing one thing, these videos are very rare these days, but there are certain changes which Arubda has shown you in modern day obstetrics, like delayed cord clamping, the baby showing to the mother, baby crawls to the mother's abdomen and chest. And so all these changes have come up with the evolution of the labor management. So those need to be incorporated, and I wonder whether any recent video will be available or not. Overall, I think Arubda, it has a very extensive and exhaustive presentation. Thank you very much. You have repeated the same thing twice and thrice just to hammer it into the student's head, which is very, very appreciable. Thank you very much, Arubda.
Thank you, Ashish. Actually, Dr. Hafiz Rohan proposed me to speak these things, rare things. So I agreed, because several times we have taught the other things. Ashish also have several other together. But these things actually very rarely taught to the student with the obstetricians. And still there are so many cases in the face vaginal delivery. So many, some cases in the particularly bigger government hospitals, like your hospital, Chittaranjan Sivasugan, and also the Arjigor My Hospital. Okay, so thank you, Ashish, for your very beautiful comment.
Yeah, I think, sir, the students still find difficulty as well as horror when there is anything they'll hear the name of face on brow, and it was really commendable, sir. You have done everything, and I am sure this will be helpful in the future also, because it will be in record in the ICOG website and in the YouTube also. So it's going to
I'll
be
recommend Hafizur that
yes,
the
sir.
student should go back to the website and run this presentation repeatedly.
That's true, sir.
Stop kar karke, so that they can understand that this thing, or they can also combine the dummy fetus and the presentation and the video. If they can, then that will be very ideal.
Yeah.
So I recommend that the student should go to the website and learn it in phase wise, like you read a novel. So today
Yes,
I
sir.
read the dummy fetus only. Then I will combine this with the lecture, and then I'll combine the video. Something like
Dr.
that.
Hafizur,
yes, sir.
My suggestion to the student, postgraduates, importance project, the message to the student, the phase delivery and for the for demonstration is easier than the face-to-face delivery. Remember, and only thing is the that is the occipital anterior to make it extended, and that will be very easier than the face-to-face delivery, particularly during examination and demonstration.
That's
so
true,
you
sir.
Just go through it, and that is very important.
That's true, sir. That's what I.
In the exam, I should not say things like that. For instance, the mento posterior is converted into gradually after internal rotation is converted into mento anterior, and rest of the mechanism is labor is the same as mento anterior. Please see page number 332. They should not say that.
No, that's true, sir. As I have told, Mazi sir told, and I am sure once they have this recording and everything is there, if they observe it and practice it, as Ashish sir you told, they will never have difficulty or fear about face or brow, and that's I am sure. Yeah, sir, I think we should go to the students are waiting for the yes. So we have already told the students, Dr. Rupa and Dr. Deepti, are you ready? And thank you, Meena madam, so much for your guidance to the students. I am sure they will do good. And we have Ashish sir, Dr. Arup Mazi sir is again there, sir is in there. Then we have Dr. Pragya Mishra Chaudhary madam, Dr. Prasanna and Shobha Godi madam. So all are known and associated with ICOG teachings. So without wasting much time, I would like to request Dr. Rupa and Dr. Deepti, please share your presentation and start presenting. And a request to the faculties to take over, please. Dr. Rupa and Dr. Dipti?
Are you there, the PG students? Are you there?
They are there.
Dr. Meena, can you call
I
them?
have seen at the very beginning.
I'll just check. They were right there.
Yeah. Maybe some connection issues.
At the moment, I don't see them.
We welcome Dr. Shobha Gudi.
Hello.
He is always a pillar of support in our faculty bank.
That's true, sir.
She is always there for ICOG programs with all her comments and all her, and Pragya with all her Pragya. Where is Pragya?
Pragya, ma'am, please rename yourself. Ma'am, you
Ah.
need to write your name because it's showing speaker.
We need to do something about this renaming business,
Yes, sir. Yes, sir.
We need to take out an alternative solution that as soon as they appear, they are automatically renamed. ऐसा कुछ होना चाहिए. I mean,
Hafizul,
technology, AI.
Hafizul,
Yes, yes, ma'am.
Ashista Hafizul,
बोलिए.
I just wanted to know, we are half an hour late. So how much time should we take for this? Because it's really
Ma'am,
it
you can
becomes
take
serious.
at least up to, I hope, up to 1:30. That should be fine. Fair enough.
Or should we make it a brisk 30-40 minutes? Because I think it's
I accept your suggestion, Shobha.
Yeah,
and
it should be brisk, I feel. I don't think we should do
Because
this
it's a
very
short
thoroughly.
case. No, it's a short
It's a
case.
short
So I
case.
don't
Yeah,
think
ma'am.
it will take very
So we can
long.
take
Meena,
45
we'll
minutes,
finish it
ma'am.
within 30 minutes. Yeah,
30
30 to 40.
30
Yeah.
to 40.
Yeah,
Yeah.
30 to
They got
Yeah.
locked out somehow, so they're connecting again.
I think
No,
we'll
they have
go
connected,
ask Dr.
yeah.
Haraprasad
I
Patana.
can see
Yeah.
them. I can see
Yeah,
them.
okay.
Yes, I can also see them. Yes.
Rupa and Dipti, please rename just quickly so that everyone can know. It's showing speaker, no?
Okay. Quickly go into the full screen mode and start presenting.
Good afternoon, respected teachers. I am Dr. Diptimai Patri and my colleague Dr. Rupa Rani, under our faculty coordinator Dr. Meena Samant ma'am from Kurji Holy Family Hospital.
Yes, certainly
From
they have
Danapur,
connection issues, right? Well, they have connection issues.
Please go ahead. That's the reason I requested on the other day. Please be on the same connection, same laptop used other day. Go ahead. I can see both of you.
Yeah, but
she is from Danapur, 8 kilometers from the hospital, made it since 5 years. She belongs to lower middle class family, Hindu, and gravitated to Para 1 and Living 1 issues. She came to us with no complaints as such, but she was advised cesarean delivery by an attending physician in other hospital. So came here for second opinion. In her menstrual history, her LMP was 15th October 2023 and EDD calculated by Neglis formula was 22nd July 2024. Period of gestation was 39 weeks 2 days. She attained her menarche at 13 years of age. Her previous cycles were regular average flow and 4 to 5 days flow. She did not have pain during menstruation and any clot passage, not associated with any contraceptive using. In her history of present pregnancy, in her history of first trimester, she spontaneously conceived, detected pregnancy by urine pregnancy test at 20 days overdue. She was a booked case, planned birth at other hospital. She took folic acid and tablets regularly. Anti-scan and dual markers were done and within normal limits. An early dating scan was available corresponding to current gestational age. There was no history of fever with or without rashes, no history of teratogenic drug intake. There is no history of excessive nausea, vomiting, and bleeding per vaginum as such. In her second trimester, she felt weakening at 5th month of gestation. She was immunized with 2 doses of injection tetanus toxoid. Took iron and calcium tablets regularly. There is no gross congenital anomaly detected in the TIFA scan. There is no history of pain abdomen, leaking, and painless bleeding per vagina. In her third trimester, she took iron and calcium tablets regularly. No history of pain, abdomen, bleeding, or leaking per vaginum. She had a growth scan at 30 weeks, which was found to be adequate for the gestational age. She was married since 5 years, non-consanguineous marriage. In her first past obstetric history, she delivered a healthy female alive baby weighing 2.8 kg, exclusively breastfed up to 6 months and completely immunized till date, 3 years back. Past surgical and medical history, she has a history of pulmonary TB at 8 years of age and took ATT for 6 months, and history of open appendectomy 12 years back. In her family history, her both parents were hypertensive and controlled on medications. No history of any chronic medical disorders in the family. In her functional history, she had normal bowel and bladder habits, adequate sleep and appetite pattern. Orodontal hygiene were well maintained. No history of smoking, alcohol intake, drug abuse, and allergies. Medication history, there is no history of any long-term drug intake except that ATT, and no history of any contraceptive drugs used. In her nutritional history, she was taking mixed Indian diet. According to the 24-hour recall method, we calculated her calorie intake, approximately 1800 something, so 1900 kilocalorie. She has a deficit of 600 kilocalorie. Total protein intake was 40 grams with deficit of 25 grams. In her social history, she was well connected by route, which takes 30 to 40 minutes away from our hospital and stays in a joint family. Family members are there who can take her to the hospital whenever is needed. So she was well prepared for delivery related emergencies.
Now coming to general examination, patient was conscious, cooperative, and well oriented to time, place, and person. She was comfortable at rest, well built and adequately nourished. Her height was 160 centimeter, weight was 62 kg, and body mass index was 24.2. On general examination, there was some pallor and mild bilateral fetal edema was present. There was no icterus, cyanosis, clubbing, or lymphadenopathy. Jugular venous pressure was not raised. Temperature was 98 degree Fahrenheit. BP was 110 by 80 mmHg taken in right arm in supine position. Pulse rate was 92 beats per minute, which was regular in rhythm, fair in volume, and normal in character. All peripheral pulses were palpable. SpO2 was 99% in room air. Respiratory rate was 20 per minute, which was of abdominothoracic type. Thyroid and breast examination was found to be normal. Nipple was well formed, no retracted nipple, any cracking or fissuring of the nipple, no any palpable lump, no thyroid swelling. On systemic examination, central nervous system was within normal limit, no focal neurological deficit was seen. On cardiovascular system examination, normal S1 and S2 was heard. There was no added murmur. Respiratory system examination, bilateral vesicular breath sounds was heard. There was no added wheeze, rhonchi, or crypts. On gastrointestinal system examination, liver and spleen was not enlarged. Coming to obstetric examination, patient was firstly informed about the procedure. After taking consent, per abdominal examination was done. Firstly, inspection. After ensuring an empty bladder, inspection was done. On inspection, abdomen was broad and asymmetrically distended. Umbilicus was centrally placed and everted. Linea nigra and striate gravidarum were seen. Flanks were pulled and there was no dilated veins. Hernial orifices were free. On palpation, after centralizing, the height corresponds to 34 weeks, which was less than period of amenorrhea. Symphysis fundal height was 34 centimeter. Coming to grips. On first Leopold grip, no fetal pole was palpated. There was empty grip. On second Leopold maneuver, soft, broad, and irregular breach was palpated in right flank, whereas hard and globular head found in left flank. Back was felt anteriorly. On third and fourth Leopold maneuver, no presenting parts were felt, and there was empty grip. Liquor was found to be adequate, and uterus was relaxed. On auscultation, fetal heart sound heard just below the umbilicus, which was 150 beats per minute and regular. On per vaginal examination, os was closed, cervix was uneffaced, long and posterior. There was no sore, no leak, no presenting parts were filled. Our case summary was Mrs. 29 years aged, gravid to para 1 live 1 with one living issue 3 years back, belonging to lower middle class family, staying approximately 8 kilometers from the hospital. Came at period of gestation 39 weeks 2 days and was admitted on 17th July 2024. She was immunized and doing regular antenatal checkups. She had no significant past and family history. On physical examination, she had some pallor and mild bilateral pitting edema was present. On obstetric examination, height of fundus was less than period of amenorrhea. Abdomen was transversely oval. There was no fetal pole in fundal grip. In left lateral grip, globular head was palpated, and in right lateral, broad breech was palpated. The first and second pelvic grip were empty. The size of baby was average, liquor was adequate, and fetal heart sound heard below the umbilicus. Based on history and obstetric examination, our provisional diagnosis was gravida 2 para 1 live 1 carrying 39 weeks 2 days pregnancy with transverse live. Then and found to be within normal limit.
I think we'll
ultrasound
stop
was
you
performed.
here. Hello. Dear
Okay,
students, you have done excellent job. Can you go back to the present obstetric history slide? Present. Yes, that one. The second, next slide. Yes. Stick on this slide. Stay on this slide, yes. I was pleasantly surprised to see the marital history after the third trimester history. You have already written about her marital status before. There's no need to say it once again here, and it is ill-timed. Can you go back to the summary slide? And before that, the obstetric examination. Yes. Go on. No, stay on this slide. Palpation. After centralizing the uterus, I don't know how, I wonder how much centralization in this case you can do, but then it corresponds to 34 weeks fundal height. Is there any standard 34 weeks fundal height in textbooks? I think after
centimeters. They have mentioned, Ashish, that they have mentioned centimeters.
No. Correspond to 34 weeks, they have written
weeks
first.
Also.
Yeah. So
you can either say, it is not there. You can say 32 to 34.
32 plus or 36 minus, and say that, isn't it? So I think careful. Today, if we allow 34 weeks of fundal height, tomorrow somebody will write 33 weeks fundal height. And then 33.5 weeks also will come. So these are fixed.
We do allow 32 to 34. That will indicate it is somewhere between 32 and 36.
You can write 32 plus. What is established in the textbook is 32 followed by 36, isn't it? So we can write or 36 minus.
Standardization of reporting, yes.
Yeah. Then come to the summary slide, please. Summary slide. On the first look, I could see.
No, I had a comment on this.
Yes. Go ahead, Shobha. Go back.
PV.
Go back, yes.
Yes. So here, I want you to mention always when you're presenting also, you should mention always that per vaginal examination was told after informing the woman and under aseptic precautions. Yes. Both you must tell, okay, as a standard, because this is what you're doing. So examination is relating what you're doing, all right? So after informing the woman and under aseptic precautions, that is very important. You should know how to follow aseptic precautions. Now you have written os closed. It doesn't have any meaning. You must say external os, all right? And then you have written separately as cervix, uneffaced, long, posterior. It should be a complete information on cervix. So begin with the information of cervix. It is correct to begin with information of the cervix, and you first mention the direction of the cervix, because it's very important to say which compartment the cervix is. It is posterior, that means there is absolutely no labor at present. So you see posterior, you are saying uneffaced, better than saying long, you mention the length of the cervix, 3 centimeter or 3.5 centimeter. It gives you more objectification. It gives you more, sense for the specialist, next one who is going to assess. So it is uneffaced, fine, length 3.5, whatever, posterior, and the external os is closed. Then you have written no presenting parts felt. So I'm just wondering here whether that is possible. No presenting parts felt at all, or were they very high up? Totally empty, lower segment, or were the presenting part high up or something? No presenting part felt at all.
I think they're just trying to say because it was transverse lie, so they couldn't.
Correct. They were trying to
why,
convey.
no presenting part felt. So that's fine, I think.
Fine. Okay. No show, no leak is more a feature of no leak, especially is a feature of pars speculum and not PV examination. Please understand that. You can mention it. I have no problem. But please remember that it is more leak, especially is a pars speculum finding. Okay. Then because okay.
So I'd like to raise one basic question: is whether they need a pars speculum examination in this case.
In this case, maybe it is not needed. It is not needed because there is no symptom.
Secondly, even parvaginal examination is nowadays restricted. But whenever you do it with all aseptic precautions, and also you gain.
Pelvic assessment has not been done, Ashishta. There's no reason why pelvic assessment should not be done here. Why did you not write about pelvis adequacy? I wanted to know the reason.
Because lie was transverse and there was no mechanism.
So that means you feel that there is no chance of vaginal birth. Then why are we having this case discussion? We need not have this case discussion.
So that is why the parvaginal examination is questioned. Okay. So we'll come to the.
Can I just make one comment on the history, because Dr. Ashish Mukhopadhyay was also talking about that. If you allow me, is it okay?
Yes, yeah, sure.
Yeah. Actually, I just wanted to tell the students that, all of that, nutritional history and personal history, all that comes under social history. So, when you start, you've taken presenting complaints, history of presenting complaints, then past medical history, surgical history that they've done, drug history, allergies they have not mentioned, whether, it's very important, allergies. So as far as
mentioned.
No, I think they have mentioned about the allergies. No, the structured history taking is what we are preaching in ICOG. So they have tried to stick to that, except that marital history came suddenly in the obstetric history. I was a bit surprised. And drugs and nutritional history, they should be separate. Nutritional history is very important in our country. Socioeconomic history broadly takes a view of the socioeconomic situations and conditions in which he is living. But nutritional history, dietetic history, these things are very, very important in our.
No history. I feel that personal history about no history of smoking, alcohol intake, etc., should really come under social history. It's age long.
They're personal history. They have written in personal only.
Yeah, they've written under personal, but ideally it should come under social history, when we talk about. But that's okay. I just.
Well, these are the structured things that we are always following in textbook also. They have written under these headings. So personal history is allergy, addiction, and smoking and alcohol intake. Traditionally, you have been writing in personal history only. Because it's not a social event, because not all people in a society starts drinking together, isn't it? Like diet should be absolutely a must in the history taking, nutritional and dietetic history. That is what we have recommended in history taking. Okay, so
with your permission, Ashish.
Yes.
Just before going to the management, I some point I will about the history taking examination here. Just they have taken just few points. Now one is the last pregnancy was 20. They have done very well, really well prepared. Last pregnancy was 2020. You have no contraception history, so you'll have to justify. The 4 years there is no baby. How there was no baby? That is the you'll have to justify. Anything you'll have to query. And you have to write some payload. Write the some payload. Payload it may some is it to write correct?
Even I feel it should be quantified as mild, moderate, or
mild,
severe.
moderate, and severe.
Yeah, or even at least mild and severe. Yeah.
I must appreciate you in sociology. You have for our postgraduates. This is the message. You write down the distance from the home, one important thing, and the birth preparedness. Whether the peoples are there to bring the patient in emergency. They have mentioned. Thank you. That is for other postgraduates. And for abdomen, you have write the for abdomen. That is the fundal grip. That is the first leopard. It is empty actually now. It is not actually empty. You know, there is no particular pole is palpable. Either
Even I feel.
That is not empty actually. And next is the whether the PV is justified. If you do the PV in this case already diagnosed by the you'll have to justify something, particularly whether the leaking or like that.
Let them justify. Let them try and justify why they did a PV.
Ma'am, she is coming to us at term, and she is a good candidate for ECV also, and she is a previous vaginal delivery. So we have to assess the per vaginum to.
Yeah, but you didn't mention pelvis is adequate. You should complete the finding. Okay, always mention about the pelvis.
Okay, I think if you come to the summary slide, it will be obvious. Students, come to the summary slide, please. That's what the point I was trying to make. Go to the summary slide.
Go to summary. Next.
Here you have written last childbirth 3 years back. Okay. But you never mentioned whether by vaginal delivery or C-section.
Yeah,
it's mentioned. It's mentioned.
It's mentioned.
No, in the history it is mentioned. In the
summary is very important.
Summary mein aana chahiye.
Summary is everything that the examiner gets. No. Okay. So that is the second thing. On the other hand, you have elaborated on the grips in obstetric examination. There is no need to make it so much of detailed in summary.
In summary.
There was no
to tell your interpretation.
So use all your energy in this case and mention at least the last childbirth was a vaginal delivery or not. That is very important fact in summary. Okay. The summary is important in all aspects and everything should be covered, like history, general examination, local examination. Everywhere you make the summary. Don't write the entire thing. If you just copy paste here from the examination, that's not a summary. Okay. So that is about the summary.
Yeah. Ashishta, I just wanted to tell them one thing about obstetric examination, that there is a little bit of difference between an undergraduate presenting obstetric examination and a postgraduate, okay? When an undergraduate presents, he will describe all the features of that part and then say it is a head. But for you, you have almost completed your training, so you should say that I felt the head in this quadrant, I felt the breech is this quadrant. And if the examiner wants to know how you identified it as a head, they will ask you. Okay, so don't describe the features of the part because you have come past that stage. So you can say it is transversely distended. You can't say transversely oval. You say abdomen is transversely distended. Okay, and there was no fetal pole in the pedal grip.
I have just one question to the students about the term distended. You know, pregnancy is a physiological event, and I don't like the term distended. I would like to call it enlarged. Asymmetrically enlarged. Distension means normal pressure.
Transversely enlarged also. That is also good, but not transversely oval. I don't know whether that will be correct. Okay. Yeah. The normal pregnant gravid uterus is pyriform in shape. The other way of saying it is oval. But when it is a transverse line, you can say transverse enlargement or whatever, and then you can say the first and second pelvic grips did not yield any fetal pole. No fetal pole felt. Don't say it was empty, because even if there is a central placenta previa, we don't say empty. We say that there was no fetal pole felt.
Polls, yes.
All right.
And I agree with you, Shobha, that in postgraduate level, that's a basic difference between an undergraduate
Yeah,
history and
नहीं
postgraduate
बताना
history.
चाहिए. Soft and
He had
bulky
some
and
pallor. This kind of statement doesn't make any sense.
हाँ,
So,
pallor should be
examiner also
quantified.
thinks, suppose you write something like this, she had some pallor. Examiner also thinks about giving you some number, not specified. So I think
Exactly.
that you should be quantifying that. I mean, mild pallor or moderate degree of pallor or severe degree of pallor. I think you should quantify in postgraduate. In undergraduate, it is okay because they are still learning. I believe that
Casual reporting, to say some pallor, it indicates
Yeah.
that you're casual about the pallor.
The abstract
Instead, you say
reporting.
it is mild. It is severe. You want to tackle it, right? And you want
Now
to be
go to
ready
the
for
management,
it.
Ashish.
Lastly, in the provisional diagnosis.
Ashish sir and Shobha ma'am, I would like to just
I have 15 minutes more.
Can I take,
Dr. Prasanna wants to tell something.
yes. The thing is, whenever, especially when you're with the mal presentations and all, regarding my speculum examination, when there is a mal presentation coming for the first time with no available previous any reports. So whenever there is a transverse layer, any others, here the chances of placenta occupying the lower uterine segment. Maybe there is no bleeding, but still the placenta can be lying down. So in those cases, first we have to do the in mal presentation followed by pervaginal examination as a routine to be adopted. That's one.
Yeah, I think that is the point. Also, because there may be some silent leaks which the patient is not aware of. That is also possible. So I think whenever there is a malpresentation, there are every possibilities of a silent leak. Either the patient complains or not, that's a different story. But I think speculum examination, I will put more stress on the speculum examination than a digital vaginal examination. So come to the provisional diagnosis. In provisional diagnosis is actually a tentative diagnosis or a clinical diagnosis or a working diagnosis. In provisional diagnosis, never put a query. Provisional
Question mark is not allowed.
Is a query, yes. Provisional diagnosis
You make
is not
a
a
clinical diagnosis.
Clinical
Commit to a clinical diagnosis.
So remove the queries
Don't put a
and
question mark.
be confident about the transverse lie. In case the examiner asks you what are the points in favor of transverse lie, you can say that, isn't it? So remove the queries from the provisional diagnosis.
And I don't think you write second gravida. You have to write gravida 2, para 1, living 1. Okay. Gravida 2, para 1, living 1. With issue 1, carrying 39. No need of saying carrying. You say 39 plus 2 weeks of gestation. With transverse lie. Okay, you can say, and with anemia. You forgot the anemia. With anemia. Whatever it is, even if it is mild, you have to repeat.
So what are your differential diagnoses? No, actually, I think that order is a bit different. Order is after the provisional diagnosis is go for some differential diagnosis. And then from the differential diagnosis to take out the final diagnosis needs some investigations, of which some of the investigations will be routine, some of the investigations will be special investigations. So I think you write the differential bring the differential diagnosis slide ahead of the routine investigations. Where's your differential diagnosis?
I don't think they have a slide. You have a slide?
They don't have. Okay. Then you tell us what are the differential, any differential diagnosis in this case?
There may be an oblique lie.
Unstable lie.
Pardon? Who is
When it
speaking?
is a case of fundalite less than period of amenorrhea, the common question you will be asked, what are the causes or there is the height of the funda less than the period of amenorrhea? So Ashish is stressing on that point, pointing also there, that you will have to remember that point also, whether it is a fetal growth restriction, whether it is the
small baby,
small baby, less liker, or there is a amenorrhea, there is a wrong LMP duty right there.
Mistaken
so
date.
that
Yes.
that you will have to, the height of the fundus is clinically less, definitely. So that is an important feature in this case. So you will have to justify and give the duty.
So why haven't you written that differential diagnosis? I think they were pretty sure. So sure that they put a double query in the provisional diagnosis and then finished it off.
I just wanted to know, are the dates well known for her?
Yes, ma'am. Early date.
Have you mentioned it? Have you mentioned
Yes,
it in
ma'am.
your history?
They
Yes,
have written
ma'am.
that it corroborates with the early pregnancy scan. They have written that.
Okay.
That is the important
Okay.
thing here.
Yeah, we can
First
go to
scan,
management. I
first
think we
scan.
have only 10 minutes left. Yeah.
Ah, okay. So you go ahead with the management investigation.
Just one sec, I would just take 1 minute. Before they go into the management, I would just like to ask the students, do you think there are any risk factors for a transverse lie in this woman? Looking at, whatever you have said, you've taken a history at length. And do you think there is any risk factor that could have led to transverse lie?
It will come
Because
in the
that's important.
management, but you can ask, but you can answer. Yeah.
Multi-parents.
Yes.
Women.
Yeah. Chala gaya.
Apart from that, anything else? No. They've
Pragya,
gone.
they got afraid of your question.
Students are not there.
I was actually, we are having an ISOPA program, and in the next hall, as I'm sitting in Lemon Tree, and I snipped out, and then I was to join
Pragya
this.
ने ऐसा सवाल पूछा
They've come
कि
back.
slide
Yeah,
show चला गया.
they've come back. Yeah.
Start
Risk
sharing
factors.
your
You are
slide.
muted. Yeah.
Thank you.
Thank you.
That's all. So no management. Thank you.
Management will be done by teachers, not by students.
No, because risk factors, it's very important, for any student to know for an exam. Because so
Yeah, in
I
other
just
words,
had that
I'll
question.
put it separate, differently, Pragya, so they start answering. Whenever there is a transverse lie or any malpresentation, what all comes to your mind? What other coexisting abnormalities will be there?
Since multi-parents.
Don't
Common
start
cause
with
if
multi-parents.
woman is primary gravida, then in primary gravida, most common causes generally uterine anomaly, like septate uterus or bicornuate uterus, or other anomaly like placenta previa.
Yeah.
There may be contradictions and fundal insertion placenta.
Yes, yes.
And in multiparous,
Placental
because
and cord abnormalities.
multiparous to cause would be lax abdominal.
You're going a little too much on the multiparous status. She's only a second gravida.
She's just
It's only
she's
a
yeah.
second gravida. Yeah. So
I mean,
those
like if you
risk
ask me, I just asked that question, but really in this case, I don't find any risk factors as such for this lady. I mean,
Yes,
well,
yeah.
she is gravida too, and as Dr. Shobha Goody is saying, I mean, she's not grand multiparous or anything. She's just so basically, there's no risk factor as such, but it can still happen,
Yeah,
as
most of the
transverse
cases
lie.
happen like this only, Pragya. So that's why the risk is something like very rare. Now, I wonder in the final diagnosis, what is left transverse lie? It is something called right transverse lie and left
When
transverse.
head of fetus lies in the left.
Head of the fetus is
left.
left.
Why
Yes, sir,
left?
depending.
I have not actually.
Did you read it anywhere in any of the books?
Yeah, left transverse lie, right transverse lie, I haven't seen in any book.
Did you read it?
When head of
May I
fetus
know
lies in
which
the
book? Which
Yes,
book you
ma'am.
read it? Left and right transverse line? Okay, what is important? Rather than right and left,
Back
what is
anterior, back
important?
posterior, that's what you mean.
Back is important.
Now, what do you have to mean the case? Left or right?
They
When
said
you will be asked in
that
exam, what is your case, which is the head, which side, dorsum you said, you clearly stated there, I have said. In the abdomen, back is anterior in this case. And the head is left side or right side. What do you mean by left actually?
Head is at the left side, sir.
Oh, head is
but
so
even,
left
even,
transverse lie.
even if you write about the head, left or right, you still have to write whether the back is anterior or posterior. That's the point.
So you need to give a complete information. You can say transverse lie with back anterior with head in the right iliac fossa or the right lumbar area. Write that, whatever, or left lumbar area or left iliac fossa.
We
like
have
that.
little time left now, Shobha. Come to the question, how do you propose to manage this case?
Management, yes, that's what I have been asking. Management.
Go to the next slide.
At first, see second gravida.
Let them talk. I think they need to talk.
Yeah.
Rupa, say. Or Diptimoy, say. Manage.
Stop sharing. Stop sharing.
So this
Stop
is the
sharing. It
this is
will
the
make
fourth,
it easy for you.
Stop sharing. You stop sharing.
the fourth time they have shown thank you and they have said second Dravida.
No, it's okay. Please start talking about management.
How do you manage this case? Bolo.
Yes. We manage this section.
So at first she
No,
is
I'm
a
little
term
disappointed
pregnancy
with that
and with
connection.
every size baby and a adequate tiger was there. We could have explained her about external cephalic version. We have explained her, but she was already preoccupied with cesarean delivery anywhere else. So she wanted to get operated and get the cesarean delivery done. So we have done cesarean delivery for this case, but we should have done external cephalic version in this type of case also.
What are the difficulties in
Because-
cesarean section delivery? What precautions you take and what is the difficulties?
Ma'am,
What are
at
the
first
precautions you
in
take
transfer
when you
slide,
post such a
there is
case
no-
for cesarean section?
Risk of uterine incision extension was
So what
more in case
precautions you
because in
take?
transfer slide there is no parts. Blood, we should
Yeah.
keep blood in our hand.
Yes. You have to
There may
arrange
be
1 pint of
PH here.
PRBC. Yeah. Which we always do for cesarean, but mandatory here. Yeah. And
Yes, ma'am.
about
In
the
transfer
consent,
slide,
is
there
there
is
any
no
change?
presenting. Ma'am.
Consent.
Yes, ma'am. An informed consent to be taken before doing
Anything
cesarean
changes?
delivery.
Anything changes? Do you want to add anything there?
If any complications and any placenta abnormality, PPH can be there, and there may be need of any
Before
kind
that,
of.
For delivery, would you like to tell them maybe the incision you may have to extend a little with very careful?
Yes, ma'am.
Okay, some modification of the incision may be required.
J-shaped incision can be
Okay.
there, inverted T-shaped incision can be there.
Yes.
How do you
So
deliver
any
the baby?
change
What is
in
the
the
actual
standard
technique?
technique requires to be informed to them, because you are saying informed consent. So no need to write it down, but inform to them that it may be required. And as you said, maybe there will be increased chances of hemorrhage, especially Pragya has already expressed doubt. Maybe there is some kind of hidden uterine anomaly. So if it is bicornate subseptate, they may bleed a little more. So that's why you have to explain. Anything else while doing the section? What special trick? What will you do while doing the section? Suppose your madam tells, hey, you take the chance for cesarean. Would you like to do this cesarean? Madam says your turn. Rupa, do cesarean. What you will tell?
And is the cesarean section is easier or difficult in transverse line? Just say if the answer.
It is difficult, sir.
Before the so many cases of the placenta actita spectrum, which case was most difficult to do the cesarean section? And during the antenatal period, particularly, patient not in labor.
Correct.
Yes, sir.
So this is
So
a
lower segment
particularly
will not be
difficult.
formed well.
Why?
That is
and
why
how,
you must
what
tell
because of
why it is difficult.
why
Sir
is
is
it
telling
difficult?
you,
Why is
giving
the
you all the
transverse
hints. Say
Madam
why
is
it is
asking
difficult.
that
Lower
question.
segment will not be formed well.
It
So
is
we have to
elective
give
case.
an
Lower segment
upper
not
segment.
formed. It is malpresentation. Yeah.
We have to give incision upper segment also. Risk of uterine artery
So you
bleeding.
want a senior to
There
be
may be
present.
any
Senior
uterine-
obstetrician should be
Yes, ma'am.
present. Yeah.
Under supervision of senior and skilled
It is better
obstetrician.
that the
with-
senior
Pediatrician
obstetrician washes up for this case, not supervision. Should be inside
Yes,
the
ma'am.
case,
There may be need of extension of incision.
whatever it is. So, okay. Then during giving the incision, what are the precautions taken? You must be a little quick, huh? How will you manage, now?
We can give
precautions
a
you
J
take?
set incision.
No, Shobha, start with the first thing first. Any change in the planning in the abdominal incision?
Abdominal incision.
Yes. Then approach to this thing.
We can give a J shaped incision or a U shaped
abdomen.
incision.
No, skin.
Skin
Next,
incision.
abdomen, skin incisions, P
Same. Phalansteal. Okay.
Yes.
Okay.
Just mention it should be generous incision. Don't try to do, it's a small one. Like, so the cosmesis has no role. You must give a
It may
nice
be a
incision.
bigger one.
Baby is important, not cosmesis. Okay, then good incision should be there. Generous incision. Then
Do you put the
then
doyens inside or
the
not? Do you put the
Sir?
doyens inside immediately after opening the abdomen or not?
yes.
No, sir. So doyens is done.
At first we will see for placenta greater. Yes, sir.
To see that properly, you need to have a doyens retractor to see the lower segment. How do you identify the lower segment?
By the presence of uterovesical fold.
And
Suppose you see a lot of blood vessels in that area, crisscross and going from this side to that side, etc., etc. What do you anticipate, or does it change your opening technique? You try an opening technique.
yes, sir, it will change. It may be placenta accreta. It may
Placenta
bleed.
accreta.
Massive
you are
bleeding may
having
be
good
there.
ultrasound, no? You are having good ultrasound.
Yes, ma'am.
You have
If
ruled
you
it
review
out.
the
Doesn't
ultrasound
matter.
examination, actually you couldn't see the slide we just saw. Thank you.
They have mentioned
the
it. No
ultrasound.
placenta previa. They have mentioned it. Yeah.
Placenta previa. Okay, fine. So now you take out see the UV fold. The UV fold. What do you do with the UV fold?
We will lift it up and then
Will you develop the bladder fold or not? Will you develop the
Yes, bladder should be pushed
separate?
down.
Will you push down the bladder or not? Bladder flap, will you develop or not? Huh?
Yes, ma'am.
Okay. Then
Okay.
Yes,
Then
ma'am.
what
Bladder
will
should be pushed down because it is.
push down. Okay, you have pushed down the bladder. Then what do you do?
What do you do?
Well,
What do you do?
You can.
Check
I
for
think
the
Dr. Gopal
vascularity
already
over the
mentioned
uterus. If
Yeah.
the lower segment is there and no vascularity is there, then we will give a J-shaped incision. In view
Initially
of,
itself J-shaped, no. You have to first give the initial curved incision, and always whenever there is a malpresentation
needed.
like this, try to retain the membrane till your incision is complete. Retain the membrane. Why is it important to retain the membrane? Keep the membranes bulging through the incision. You can see the cord, no? Then you'll be able to avoid it, right?
Yes, ma'am.
So keep, you will, correct. So
Cord
you don't want to
Injury to the
handle the cord
vessels.
too much. First, develop the incision. After that, let the liquor out very, very slowly, so that there is still some liquor inside for you to
Yes,
bring down the leg. So which leg you will bring down? How will you deliver? You'll deliver through breech, isn't it? You'll deliver by breech. So
yes, ma'am.
back is anterior. Which one you bring
First
down?
we'll look for the
Foot in was
posterior leg will be delivered first, then the
Correct.
anterior one.
then whole
Then
body will
holding
breech
the
extraction.
breech extraction will be there.
Baby should be covered with warm autoclave towel. Don't forget that. Okay.
Shubha, it will be very difficult for a first year student to answer these questions unless they have gone through a bit of experience or at least seen these.
They should be able to tell. Once
Definitely.
you get the foot, actually, it is similar to breech, isn't it? Once you get both the feet out, it is similar to breech.
Okay, I think this is the last question because Dr. Harar Prasad Patanayak, I can see him with all his medals in the background. So he's smiling and waving at us. And we would
Good
like
morning.
to.
Good afternoon, Haro. Dr. Haro.
Good
So the
afternoon,
last
Hara,
question
sir.
will be any other, with the
Good
cesarean
afternoon, sir.
section, any other surgical intervention that you will do in this particular case?
Also,
With the cesarean section that you have decided to do, any other surgical intervention you'd like to do?
Surgical incision. That is very important here.
Hmm.
And every just standard books are there. In transverse lie, you have given the transverse incision. Any other surgical incision? Dr. Mukherjee is asking.
Yes, sir. We can also give longitudinal incision over the uterus or longitudinal incision over the lower segment and can extend it up to the upper segment in case of difficult.
In which cases will you do that? In which cases?
When we are anticipating difficult delivery in, in, uh, transverse incision, big baby or.
Ma'am,
Yes, ma'am.
bladder should be pushed down.
Yes, ma'am. Bladder should be pushed down.
Bladder should be pushed down.
Yes, ma'am. Bladder should be pushed down.
Okay.
Impacted bridge.
So there are lots and lots of answers. Please go back home and read them up. And so I'd like to close this session with the
Last one.
yes,
Only one.
Dr. Prasanna.
Regarding, I'd like to say something. When you open the abdomen and you see, you see there are a lot of vessels which are crisscrossing in the lower uterine segment. Then you think of. So before that, always we should know that whatever the previous scars or else any malpresentations, one should see for the placental location, its lowest border where it is and highest border where it is. So accordingly, you pre-operatively you decide for incision. Even the ruling out the placenta accreta spectrum should be well prepared before the incision is done. That is the most important.
Yeah. Okay, thank you very much, students. You have done wonderfully well. But then there are some things which are deficiencies we need to do.
Just one thing I wanted to say, I think both Dr. Shobha and Dr. Ashish had already mentioned, but really, transverse like a senior obstetrician has to be present, cannot leave it on the junior. Because I've horrendous experience, while delivering a transverse slide baby, and and during the time, she continues to bleed also. So I think, well, it's good for you to to know everything about transverse slide, but definitely, I think a senior obstetrician should also scrub up, at the same time.
Senior नहीं भेजा इनको. Senior वहाँ खड़े रहते हैं. Dr. Meena Samant.
In your case, the
teacher
back
has.
is anterior. It is very difficult to deliver.
Yeah,
If
that's
the
one of the difficult
holes
cases
are
to handle.
ventral aspect is the anterior, it will be very easy to deliver. But back
Yes, sir.
anterior, it is difficult. That is Dr. Pogga has correct. As a senior obstetrician should be present.
Yes,
Thank
sir.
you. Thank you, Rupa.
So I think
Thank you, sir.
They have
Ashish,
done
sir.
very well.
Yes.
Patnaik sir is ready, sir. Ashish, sir.
I know. He's always ready. But I think I will close this session of the case presentation
Before
with
you
immense
close
amount of
it,
thanks.
Ashish,
And
I have certain things to tell to the
okay.
students on
On
behalf
this
of you.
transverse lie, sir.
No. I want to say the students that all these teachers are very excellent and experienced teacher. But please remember that they are very soft
Yes.
examiners. Wherever they go, the students are very happy, and because they always they are different during examination. They are excellent examiner. You should be at home with these teachers. Excellent teacher, excellent examiner. That's all I want to say. I have experience with all of them. So you will love them to and like them, that they should be your examiner in batches
Yes.
after batches.
True, sir.
Thank you so much, Haraprasad ji. Or
Thank you.
I would like to convey my thanks to the faculty members, Dr. Pragya, Dr. Arup Maji, Dr. Meena Samant, who sent them for the C-section, Dr. Prasanna, and of course the students who have done wonderfully well. Hafizur,
Thank you so much, sir.
Much improvement after 2 days. Meena, they have done much improvement.
Thank you, sir.
In the
Thank
dry
you,
run.
sir, for
Thank you.
sir, thank you
a
for
little bit
giving
of,
us the
No, it is the credit of the guide.
opportunity, and next time our third year students
yeah.
are going to
Last year
present
they have
better
presented very
next time.
let them evolve. Let them
But
see
they've
more
done a
cases of
good, yeah.
transverse lie and malpresentation.
Yeah.
Okay, Hafizur, please call our next speaker, our well-known Dr. Haraprasad Pattanayak, sir. Welcome on behalf of ICOG.
Namaskar, Haras sir.
Namaskar.
Thank you so much, Patnaik sir, for joining. And I'm sure that is sir is a very well-known person that is everyone knows in FOGSI, and the students also knows. So as Maji sir made face and brow very simple, and I'm sure Hara Patnaik sir is going to make vaginal hysterectomy, whatever the steps, that is going to make very easy and simple to understand, as well as for them, for the students.
Performing
So,
also.
yes, sir. So we will not, because we are getting late. So over to you, sir, Hara Patnaik sir. Ashish sir, anything you want to say?
No. There is nothing much that you can add about Haraprasad Pattanayak. He's a very well-known vaginal surgeon.
Yes, sir.
All over India. And I have seen him conducting many
workshops.
vaginal surgery workshops.
True,
in
sir.
FOGSI, in AICOG, in local conferences, in regional conferences, and of course in many CMEs. So I believe
Thank-
Dr. Haraprasad Patnaik is just the right kind of person
To
to
speak
do
on.
justice to this kind of a topic.
Yeah,
Thank you
so
very much,
that's
Dr. Haraprasad Patnaik, to agree as a speaker on this program. And I think the students will be largely benefited.
yes.
Are you able to hear me? Hello?
Yes, I can hear you, sir. A bit of feeble voice. Could you increase the volume and make the presentation full screen?
I am trying to make my presentation full screen.
Your voice is very low.
No, I have not spoken in my original voice.
Okay.
Let me first share the screen, then I will talk.
Okay. 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 Accepted.
सर आपका प्रेजेंटेशन जो है वो मिनिमाइज है सर.
मिनिमाइज ये है.
हाँ. इसको
full screen.
हाँ. We
Yes,
can
sir.
the presentation make it full screen. That's all.
Oh, so I have to. अभी full screen नहीं हुआ है ना?
नहीं
Full
सर
screen
अभी नहीं हुआ है.
है.
हाँ.
आप वो कप में क्लिक करो. कप में this cup.
हुआ?
हो रहा है.
नहीं हो रहा है.
नहीं हो रहा है.
Okay.
दोबारा क्लिक करो.
सर एक बार शेयर स्टॉप करके दोबारा एक बार करके देखिए सर. That you can stop sharing and then do it again.
Click on the cup now. This cup. Yes.
Yeah,
now it's
perfect.
done.
Okay.
Now you are audible, visible, and your slides has seen.
Thank you. And I am really thankful to my dear friend, Professor Ashish Mukhopadhyay. We have spent many days and many evenings together, and he is an excellent teacher. So also Arup Maji sir and Dr. Pragya Mishra and Dr. Meena Samant and Dr. Sobha Gudi. I was listening from the beginning, and they are excellent teachers. And thank you, Hafizur, for inviting me and to say about vaginal hysterectomy, simplifying these steps, and blessings from Lord Jagannath. And I will be telling certain hard facts to the students. And before I go to the presentation proper, we all know that hysterectomy is the most common operation next to cesarean section, both by gynecologists and surgeons. And I tell that this is the second most major surgical procedure in female next to cesarean section, about which you are all discussing from your excellent teachers. So around 600,000 hysterectomy are done in USA every year, and around 30 women per 10,000 women in UK, they undergo hysterectomy in United Kingdom. And by the age of 60, 1 in 3 uteri are removed in women after the age of 60. And India, they say that statistics is 12 to 13 per 1,000 cases. And India being a very vast country, the most populous country, we have rightly said by Dr. Siri said that we are the largest number of uteri in the world. And the number of hysterectomy performed here will far outnumber anywhere in the world. So first let me tell about the term non-descent vaginal hysterectomy. Non-descent vaginal hysterectomy by mean we say that this uterus has not prolapsed outside the introitus. We know that there are prolapsed uterus and non-prolapsed uterus. So non-prolapsed uterus meaning that the uterus is at its normal position with all its ligaments attached to it inside the pelvic cavity. So once it comes out with that called the prolapse uterus with bladder anteriorly, rectum and intestine posteriorly, that we what is called as prolapse uterus. So we named the term as non-descent vaginal hysterectomy to specially mention about those uteri which have not come down. Now the term non-descent has been removed. All cases we say it is vaginal hysterectomy. So let's stick to this. So is it really difficult? Because we never try to remove a uterus which is in the normal position, which is not coming down, and how do you deliver it vaginally? Because we are operating in a deep and narrow space which we call as vagina. Vaginal canal is deep, it is narrow, and through that narrow you have to bring the uteri, appendages, big uteri. There is poor visibility of the operating field. Almost they say it's a blind procedure, which is in fact it's not, and difficulty in putting clamps and stitches in that narrow spaces, and no place for the assistant to see inside. There will be two assistants on the two sides and they will not be able to see. So let's start with a very simple case. Think about the uterus, which is around 8 to 10 weeks size, and it is a multiparous omen. So if in a multiparous omen, the vaginal canal is capacious. So that you can put your finger, you can put your clamp, there is a lot of lateral space on the lateral side of the uterus. And the previous cesarean section, no history of previous cesarean section. Why we give so much importance to cesarean section? Because there will be adhesion of the bladder to the uterus. So it will be difficult for you to do this surgery, and adequate exposure, good light source, good assistance, and good instruments. But there are simple instruments, clamps and cautery will do the thing. So in the earlier stage, let's be tell, there are a lot of controversies were there, where how to select the route. So even though vaginal hysterectomy is the oldest procedure than abdominal and laparoscopy, it was abandoned for the time being, and it went into the back seat, and we started doing more and more abdominal hysterectomy for non-descent uteri, and then the age of laparoscopic hysterectomy came, and everybody started removing the uterus by the laparoscopic route. And then we thought that if these uterus are normal size, there is no contraindication, why not to deliver with a natural port of entry? Why do a minimal invasive surgery even? Then came the concept whether you will do clamps or without clamp, stitch first and cut. No clamps is required. Then the concept started whether you use suture or do not use suture, rather burn them and cut them so that the thing is done simply. For a vaginal hysterectomy, you need to plan it. So the first thing is that every cases has to be examined properly before the proper surgery is done, which we call the pre-operative planning. So first of all, pre-operative feasibility and assessment is required. So after general examination, if you do a pelvic examination, which is very important. In a pelvic examination, you will ascertain the size of the uterus. If there is any mass or a tumor, where the tumor is, that is very essential. Then you will see that whether you need to do a vaginal hysterectomy in this case or not. That is there should be a genuinity of the indication. So if the uterus is very large, or there is a multiple cesarean section, where there is endometriosis, where you think that I will find difficulty in delivering this uterus, I may injure the bladder, I may injure the gut, so there must be a genuine indication. And look at the symptomatology. The patient must have menorrhagia or heavy menstrual bleeding. So that is one indication, or there must be multiple myoma. This symptomatology will decide that you should do the hysterectomy in this case. Then you have to assess. Most important is the pre-operative sonography examination. Pre-operative sonography will help you in locating the myomas, whether it is cervical, whether it is fundal, whether it is anterior, whether it is posterior, whether there is any associated ovarian cyst or tumor. This is very essential. And in some cases, you may need laparoscopic assistance, particularly endometriosis. So anesthesia, OT setup, and assistant is important. And again, the position of the patient is very much important. Modified lithotomy position, the legs abducted so that there is enough space for the surgeon to operate, putting his head there. Before starting the procedure, after the anesthesia is given, the surgeon like to examine it under anesthesia, which we call as EUA. In a case, because it is very essential. Why? Because when they are doing a pelvic examination or examining under anesthesia, you will be able to feel a relaxed abdomen, and you will be able to assess that whether it will be delivered vaginally or not. Skill development is definitely necessary. That is why we conduct operative procedure and do serial training camp procedures so that people will get trained, the postgraduate will get trained. So for vaginal hysterectomy, there are certain surgical techniques. This is applicable to all surgery. Why vaginal hysterectomy only? So the first and foremost is maintaining hemostasis. So do not allow any bleeder to. So how do you see? You see always the bleeding, hemorrhage for the surgeon and oxygen support for the anesthetist are the two greatest things for a surgical procedure and an anesthetic procedure. So you should see that you will not allow the bleeders should be properly ligated. Second thing, the steps has to be simplified. I will come how we are going to for the steps. And preventive surgery, meaning that take care of the bowel, bladder, ureter before. Do not try to injure them, then you try to repair them. So preventive steps are more important than anything else, and recognizing the problem and managing them rationally. Identifying the surgical limits and the patient safety. So you must see how big I can do, how I will go to that certainly, why I am saying this. And more we do by vaginal route. For hemostasis, you may use hemostatic agent. You see, capillary oozing can be prevented or reduced by tranexamic acid or epsilon amino caproic acid. Certain times, when we are going to do a myomectomy, we use adrenaline-rich normal saline or vasopressin so that the entire field become chemo. So there is complete avascular so that you will be able to perform surgery. Some people use a lot of normal saline, around 150 saline all around the cervix, and make the area blanch and deliver the uterus, give the incision to deliver the uterus. Second important thing is that getting the proper tissue plane. If you get the proper tissue plane, the line of cleavage is very important because the tissue will spill automatically from the uterine surface. The third important thing maintaining hemostasis is a electrosurgical device which we call the ESD. And if you have a proper electrosurgical device, it will bipolar or a vessel sealing device, it effectively seals any vessel up to 7 millimeter diameter. The biggest vessel you encounter during vaginal hysterectomy is the uterine vessel, which is 5 millimeter in diameter. So it can be properly sealed. Are you able to hear me, Hafizur?
We can hear you, but the voice is, as I said,
Okay.
it is
I will raise the voice again.
Yes, now it is audible.
Now you are audible? Yes.
Yes.
So let's go for the steps. So the first of all, you must assess the pouch, which we call anterior pouch and the posterior pouch. The anterior pouch is the pouch between the bladder and the uterus, and the post uterovesical pouch, which is called the A pouch or the anterior pouch, and the P pouch is the pouch of Douglas, and this is the anteriorly the uterus, posteriorly is the rectum, and in between is the pouch of Douglas. And this second thing is which you must do, whenever you have opened the anterior pouch, you have opened the posterior pouch, you have to put your clamp very close and parallel to the uterus. Do not go laterally, or do not put a clamp tangentially. It should remain close to the uterus and rather on the uterus and parallel to the fundus or the body. Second things, whether you will use suture or sutureless, we will come to that. Then the next procedure we called as a debulking procedure, where the size of the uterus is big, and if you want to try the remove the uterus through the vaginal canal, it is not possible because it is big. So you have to debulk by coring, cutting, or using a myoma screw, or delivering one after another. Throughout the procedure, please maintain adequate tissue respect and maintain hemostasis. Now comes the technique. I just told you, if you adopt a good technique, any surgery, a good technique is important. If you adopt a good technique, the surgery becomes easy. There will be less bleeding. The line of cleavage will automatically come. The uterus will be filled automatically. So the first is debulking and coring. I will show how we do the debulking or a coring. So after the uterine artery is ligated on both the sides, so the bleeding will be reduced to minimum. Then you can give a vertical incision from the body to fundus, a longitudinal incision on the uterine body, keeping the two speculi on both the sides, and give a tangential cut and remove uterine tissue in piecemeal. This is called coring. And use a myoma screw. When you see a myoma, overcut, put a myoma screw, pull it. The pseudo capsule will be stretched, and then you gently use a tip of the scissor as a fulcrum and deliver it. And next important is a previous cesarean section, where you expect that the bladder is adherent in the midline. Bladder is adherent. So, but the peritoneum is adherent there, but it is loose on both the sides, which Dr. Siris said told they are lateral windows. So you have to find the lateral windows where the peritoneum is loose. So come from both the sides and proceed inside. And again, vessel sealing device. So earlier we are thinking that the first thing I told you, if you have a 8 to 10 week size uterus still in the pelvic cavity, it was easy for you to do. But other big uterus, multiple myomas, we are thinking that they were not possible by the vaginal route. So with the broadening of horizon, we are able to deliver the uterus, big uterus, we are able to remove the ovarage and the tube by vaginal route, removal of adhesion, removal of large myoma in a case of repeated cesarean section, multiple abdominal scar, pelvic endometriosis, nulliparity. These are the things which are originally we were thinking that it is difficult to do vaginal hysterectomy in such cases. So I have already told, but I just want to say that we do a lot of case by sutureless hysterectomy because you are using a vessel sealing device. So what we called in your OT sealer. So it is nothing but a electrocautery, but it has got a wide range of wattage from 50 to 150 watt, and it has got 2 monopolar, 2 bipolar, it has underwater cautery, it has got a bipolar clamp and bipolar scissors. So bipolar clamp means, and the current will pass from one tip to other, and the tissue which is held in between will be coagulated or cut, so that there will be no spread of any current on the body of the patient. And there will be least lateral spread. It is auto stop, auto cut, and you have got multiple pedal. This is Martin maximum which we use. There are a lot of cuttery which is available. You can see the wattage. This is cutting, this is coagulation, and you can use the pedal whatever you can use, and you can also standard your program in this. What do? You can see doctor Ashish Mukhopadhyay uses a cutting current of 65 watt and a coagulation current of 75. So he can program and write his name. So you just press Ashish Mukhopadhyay, his designated current wattage will come. It is not the only, the market is full with vessel sealing devices sealer today, starting from Thunderbeat, Allen, Ohm, Salya. So many companies have come up, and this has made our surgery easy. So with conviction, with inclination, with perseverance and indulgence, you can do more and more difficult cases of vaginal hysterectomy. So the mental block of gynecologist, I don't mean postgraduates. So the descent, access or size of the uterus or adhesion, these mental blocks has to be removed. So the barriers of hysterectomy, scar is it, size is it or skill it is, has to be abolished, and you can do in difficult cases. So the large uterus is this. The first thing we say that big uterus. I told that originally when you start with a smaller uterus and normal size, bulky uterus, 6 weeks, 8 weeks, 10 weeks, 12 weeks. But beyond that, when it become abdominal, 14, 16, 18, 20, 24, 26, many people claim so that if it is big, you can adopt a technique of cutting and coring, but the limit is how much you can do. And remember, if the uterus is elongated vertically, rather than broad laterally, it is the elongated uterus, even though it is large or if it is same volume, you will be able to deliver it vaginally easier. Fibroid uterus, most important is the position of the fibroid. If the fibroid is in this body of the uterus or a submucous fibroid which is projecting into the cavity, when you do a debulking, the myoma is visible. You can use a myoma screw and you can do this. The body and the fundus, most important is that if it is more subserous myoma in the fundus, it is very difficult to turn the uterus, and that is why it is very important to do a pre-operative ultrasound examination to ascertain the size of the myoma and the position and the location and the number of biomas, which is very, very essential. I have already told you about previous cesarean section. The bladder is adherent anterior in the midline. So chances of bladder injury while opening the anterior pouch, please do not struggle to open the pouch. The pouch will automatically come down. Use a sharp scissor. Do not use a blunt dissection, or don't try to rub with a gauge piece. And identifying the lateral windows, I have already told. See, it is already told in earlier stage that it is difficult to deliver the tubes and the ovaries in the vaginal route. In fact, it is not. So because after the uterus is removed, identify the round ligament. Catch hold of the round ligament, cut it. And once round ligament is cut, you will be able to assess the infundibulopelvic ligament. Take a right angle clamp and put which you called as Dr. Said's clamp. And this right angle clamp, take the tubes and ovaries together, and you can deliver it very easily. Previous abdominal surgery per se is not a deterrent. There will be ghastly scars on the abdominal wall, but we are worried about the omental adhesion, the intestinal adhesion to the uterus. So in such a situation, while you are proceeding and going up and up, there you should identify the structure, excise the adhesion, and then you will be able to perform. Yes, pelvic endometriosis, particularly grade 3 and grade 4 endometriosis, they are difficult case because the anterior pouch is obliterated, the posterior pouch is obliterated, there is adhesion of the gut to the posterior surface uterus, bilateral chocolate cyst and teomas. In such a case, you can take a laparoscopic assistance, and because it will be difficult to find the cleavage. Nulliparity, because if there is the introitus is tight, there is least vaginal space, so vessel sealing device will be there. I will come to the conclusion later. Let's go to this procedure again. So the vaginal hysterectomy is the oldest recorded in the history. It is familiar with gynecology since time immemorial. There is reduced mortality and morbidity, and in obese patient, in elderly patient, in high-risk patient, it is a preferred route of removal. There is rapid recovery, shorter hospital stay, minimal blood loss, minimal instrument, and minimal complication. So the disadvantage is that there is no glamour. So if there is no glamour, no money like laparoscopic hysterectomy, surgery from minute rather than hour, need for good anesthesia, light and assistance, difficult to learn, but the certain challenging situation, need for meticulous surgical skill and non-complacency. It is never a blind procedure. Always you see under vision, then we proceed further. See, this is a procedure which I want to say that we infiltrate, we use single-bladed speculum anteriorly and posteriorly, so that you take care of the bladder and the bowel anteriorly and posteriorly. Catch hold with a tenaculum or a Alice tissue forceps, infiltrate with adrenaline rich normal saline, and they open the anterior pouch. Give a bolt cut, you can open the posterior pouch. If they are not opened, don't bother. Proceed further. Here I am using a vessel sealing device. I will show another. So this is it is blue in color, means it is insulated. Only the inner side of the blade, the tip is not insulated, and current pass from one tip to the other, and I am able to coagulate. The current wattage which I am using is 70 watt, which I am comfortable with. If you increase the wattage, it will burn, or it will char, it will cause charcoal, but it will not cook properly. If you reduce the wattage, it will take a long time to coagulate. So a proper wattage which is so good for you, you should be able to do this. And so what you want, you should have a optimum wattage, which will be, I use 70 wattage, optimum wattage which is essential, which will coagulate the tissue. And the first important thing is you see the transverse cervical ligament or the McIntyre's ligament. Then we proceed up and take care of the uterosacral ligament. Now this is the technique called coring. After ligating the uterine artery on both the sides, I have to cut the uterus in the longitudinal fashion. So what is there? So the cavity is opened and you see a myoma propping it out. And that is the place, and if it is projecting, rather overcut it, they put a myoma screw and try to pull it. And the pseudo capsule will be stressed using a scissor, and so that this will be easily delivered. And there are multiple myoma in this case. Please see that you are taking care of not injuring the bladder anteriorly. So the speculum is there to protect it, because the chances of injuring the bladder, it is on the side near the cornea. So take care of this. And if it is sleeping at all, we use this instrument we call as a cat's paw. If you are holding with a cat's paw, this will not slip, unlike a Alice tissue forceps. And once it is there, and and you can pull it further, the pseudo capsule is stressed, put a tip of the scissor, try to deliver slowly, and the myoma will come very gradually. This is a big myoma. You can see it because of the stress. Now, after this myoma, the size of the uterus becomes smaller too. And now that, so the upper pedicle, there are three main pedicles which we are coagulating or ligating. The number one is transverse cervical or McIntyre's ligament or uterosacral ligament. Next comes the broad ligament, where you ligate, and the upper one is the complex of tubes, ovaries, the ovarian ligament and the round ligament. And the next myoma comes here, and again this is another big myoma. Even the size of the uterus may be big, and because the myoma are removed one after another, it gradually comes in this size comes down and it is easier to deliver the uterus. So initially it may look like an uterus of 16 to 18 week size, but a preoperative planning, you see that there are myoma which is easily or conveniently can be removed so that it will not cause any problem. Another myoma at the fundus, and it is still there, it is so that if you try to deliver the uterus in such a situation, there is least space of ligating the upper pedicle. So it is better to deliver the myoma first and reduce the size of the uterus, then put your clamp or coagulate. So this myoma, even the uterus is already delivered out, up and down. The fundus is on the posteriorly now. So this myoma, you can see clearly the pseudo capsule, and the myoma is pulled gradually. Please remember one thing, at this step, be very, very cautious so that the uterus is not pulled out. If you try to pull out the uterus, the upper pedicle consisting the tubes and ovaries along with the covered blood ligament may be stretched and torn, which will cause bleeding. You can see that the ovaries is seen on the sides, to the left of the patient. You can see in all the situation, try to keep the tip of the cautery or the tip of the scissor away from the internal organ. If you are trying to close it, you can see the ovary on this side, and please coagulate it properly, and so that there is no further bleeding. The uterus is delivered. This is a large size uterus. It was a 18 week size uterus, but because of multiple myoma and we delivered them one after another, the procedure has become easy. Now, check for the bleeders inside, and once the bleeder are checked, so that bleeders are checked, your procedure has become, you have assessed that there is no further bleeding, you try to close it. I will like to so the take-home message here will be a vaginal hysterectomy is the preferred route of removal today. Any you try to be to undergo hysterectomy, the vaginal route should be the preferred and the first route. If you are not able to do it, you can take laparoscopic assistance. And all you try, barring a few, can be delivered vaginally today. The vessel sealing device is definitely a boon because I do it, but still then there are place of clamps and stitches. It helps in different situations. And next one is, please remember that once you proceed with, start with normal size uterus, start with bulky or up to 8 to 10 week size uterus. Do not start with difficult vaginal surgery from the beginning. And training and experience and expertise really matters. Size of the uterus is immaterial if you can do it or if it is convenient. But identify, know your limit and see this properly plan, or you can take training or retraining and you can go ahead. Vessel sealing device is a boon. Laparoscopic assistance is definitely whenever necessary, and correct decision for surgery is mandatory. And that is why I gave so much of importance to a preoperative planning. So it was told that will NDBS be difficult? I think if the 3.5 kg baby can be delivered vaginally, then why can't a 36 week size uterus can be removed similarly? And the sky is the limit, and that's not a joke. So the thing is that newer concept of modern electronic gadgets are coming up, which the concept of vaporization has come up. So instead of doing this, the simple vaporization can also reduce the size of the uterus and you can deliver it. If I have still time, I can go and show other videos, or I can stop here, or I can take questions. Hafiz?
Yes, sir.
Thank you very much, Dr. Haraprasad Pattanayak.
Yes.
Rising talk is very visually pleasing, and we were witness to good surgical expertise. And an experienced surgeon like you, it looks like a cakewalk. I remember one statement from Dr. P.C. Mahapatra that experience is always desirable.
Yes.
And that the experience always comes from bad judgment.
Bad judgment.
So initially you have to start with wrong selection of the cases, get a painful history, and then you gain experience and then you do this.
I
So,
would like to tell it in a different way. So start learning from a experienced person, a professor like you. Start doing simple cases. Then as you go up and up, you can do more and more difficult cases. Then go for another training or retraining or the different workshop we are doing and a lot of things. Then everybody will be able to do more and more difficult case. It is definitely experience of yours and experience from others. You can learn how to do, because even the steps we are telling in the previous session, how to do cesarean section in a proper way, how to deliver the baby even vaginally. These steps are learned and they are learned from the teachers like you. Thank you.
Correct. And sir, another thing is that whenever we teach our students, we always say that first you start with the simpler cases, like from even laparoscopic hysterectomy also is taken, multiparous women, almost prolapsed, and easy case, etc.
Yes, sir.
But in exam, I have stopped asking this question. I used to ask previously. Now I have stopped asking the question, what is the best route of hysterectomy? Because the students are confused. A laparoscopic surgeon will say, I can take out even a 36-week uterus also.
Yes.
A vaginal surgeon, a natural vaginal surgeon, a gifted vaginal surgeon like you, will say, I'll take out 36 weeks uterus vaginally also. In the middle, poor abdominal surgeons like us, they are struggling taking out the 36 weeks uterus abdominally also. So I have stopped asking this question that what is the best route of hysterectomy. That has given rise to many debates in many societies, but now we have stopped. Sir, thank you very much for this excellent talk. Because of paucity of time, we could not complete your other adventurous videos. And some other time, sir, we will see whether we can see these or not.
Thank you.
Just
it's
one
a treat.
thing.
It's a Madam Sobha Gudi. It is a treat to discuss with Ashish Mukhopadhyay. He is such an excellent person that he has answer to everything, and whatever you say, he will make a thing out of it. And we have many memorable and things in the past. Anyway,
Ashishta is really something to reckon with. I agree with you.
Yes.
That's why we acknowledge him as big brother, no?
Yes.
So I just wanted Hafiz, I'll just take a minute to I am also a very strong proponent of vaginal route of hysterectomy, especially. And we do in our unit, we do vaginal route as a preferable route. And one thing which we must remember is what Dr. Shirish said when it comes to choosing the route of hysterectomy. The postgraduates can just answer it like this, whatever he said, that whichever uterus can be removed from the exclusively from the vaginal route should be done so in that surgeon's hand. So if the surgeon feels that he can take it out by the vaginal route, then he should not be offering any other route.
Yes.
Because this is the least invasive route.
Natural route.
It's the natural route. It's a natural route surgery. And I think we also need to progress and learn about the V-notes technique which has come in. And maybe that will also bring about a difference, because it does look like that may have an edge over the robotic hysterectomy which they are doing. So that is there, and about the equipment which you used, how expensive that is, I wanted to know. How much it cost you?
Madam, now that I purchased it in around 8 lakh rupees way back, they are charging somewhere around now, but you should go for other countries. Because Alan country is good. They come around with around 4 to 5 lakhs. Even Salya, which is very much popular in West Bengal and Orissa, you can do. But the important thing is that even Thunderbeat and Vesilar, they are expensive. But what is important that you should be satisfied with the instrument. There should not be any leakage of the current, and this should be effectively sealed. That is why the proper sealing will be good. And I am comfortable with Martin Maxwell. I am comfortable with sealer. Prasanna, you want to say something?
No, sir.
And because that is what is more important. And many people, I went to Allahabad, Dr. Ashwini Bansal, he was using Thunderbit a lot. And because it depends on the surgeon, they always say that the my
Principal, sir, is only bipolar coagulation only, no?
It is
Principal
bipolar.
is bipolar.
Over the extra thing is that it has to once the tissue is cooked properly, it will stop, which is called as auto stop. It makes a sound, it makes a beep, and it stops. Even after that, if you press the pedal, current will not pass. That is very important.
That's a typical vessel sealer. It's a vessel sealer.
They usually the arterial, the tissue is actually coagulated, and the collagen gets fixed, glued together. So there will be no bleeding at all. That is the essence of a electrosurgical device or a bipolar cartridge. Yes.
Thank you so much.
So I think that with the advent of these gadgets, I have seen him performing many sutureless hysterectomies, and it's really the only thing is that the trainee at the beginning point of his or her life career, he thinks that he's very scared of two things. One, the vessel sealing, if it is not properly doing its job, then bleeding starts. And secondly, the slipping off and causing passage of current. So I think that what Haraprasad said is very important.
I will tell you one thing.
Yeah.
The first and foremost thing, using the proper wattage, which is essential.
Yeah.
I told you that if you increase your wattage so that you want to do it fast, so you increase the watt up to 90 watt. Immediately when you press the pedal, the high high wattage will be there, and it will char the tissue. But we are not interested that it will char. There will be a lot of carbonization, but the coagulation will not run. The fusion of the collagen will not occur. So that if you reduce the current wattage, that will take a long time to coagulate.
Longer time, yes, but it will be safer.
It is the optimum wattage, which is very essential. Second thing is that at the application of this, you should remain very close to the uterus. You should play parallel to this uterus, and you should not grow laterally.
So you have said these things, yeah. Yes, technical aspects. So the charring effect, which happens because of the increased wattage, which many people may do at the initial part, then they realize.
Yes.
So that is like a fast food, which is not good for health.
Yes.
It is not good for health of the surgeon also, the uterus also.
Yes.
I think that the slow cooking, which our grandmothers used to do, over few hours of rice cooking. Yes. And today's youth, they are going for purchasing a egg roll maybe or a chicken roll and have it and throw the packet there and come back home.
Yes.
So that
technique you are right, Hara sir. He has got very.
So
he explains things very well. That's a wonderful analogy.
Yeah, you need to do slow cooking of the tissues.
Slow cooking, correct.
That perfectly demonstrated by Dr. Haraprasad Bhattana. I think it's a wonderful lecture. So give him a big round of applause, sir. Thank you so much for the budding postgraduates and also not so budding postgraduates like me. I think it's a wonderful session that you have done. That at least it sends some technical details. So aata rahega, sir. Zindagi bhar hai. Lekin the message that you have said, that vaginal approach is a safer approach, the natural approach. And if you're taking your learning properly, you must take your learning seriously, and then take the training from a good surgeon. Then I think you can do wonders in the history. So thank you very much, sir. I would like to add Dr. Ashok Kumar is there. In absence of him, I would like to politely invite some comments from Hafizur or maybe from Dr. Prasanna and then close it. Dr. Shobha has already spoken.
And the postgraduates.
Dr. Prasanna, and you want to say something? Yeah.
Do you want to say something from the postgraduates?
The postgraduate, you want to listen to them, sir?
Yes, sir.
Yeah. Deepti and Rupa. Yeah, please go ahead. Sure.
Thank you, sir. Thank you for giving us
feeling?
the opportunity in first year.
Oh,
It was very informative for us. Thank you so
It
much.
was very learning point for us. Thank you so much.
Thank you.
So in
Maji sir,
future,
you are
in next 2 years, you have 2 more years for training. You observe and look for the cases of malpresentation in your hospital and
Yes, sir.
observe them closely how they are managed. So we'll
Yes.
come back to you in the 3rd year to see how proficient you have become in handling such cases.
Yes.
Okay.
Yes,
So all the
sir.
best for your future. Thank you
And
so much.
I am sure.
Yes,
The last
madam.
stress, whether by laparoscopy or by abdominal, we never ever think of doing by vaginal route. And the way you are taking out one fibroid through vaginal route, it's really, let us do this surgery also. It's like one of the
I'll do it.
encouragement.
Please.
One should try to do this.
We are
surgery.
always ready. Always
Yeah.
ready. Always ready.
Really,
Correct.
really.
और हम तो पूछने ही वाले थे सर और कितना है और कितना है सर और कितना है सर निकल नहीं जा रहा है Thank you.
Fibroids.
Thank you so much. Maji sir, you are there? You want to say anything?
Yeah.
Yes, sir.
I am here.
Last comment, sir. Yes, sir.
We'd like to see Dr. Maji. He's not visible. He's audible.
Video.
I am trying. This is actually the fantastic program. ICOG program, and thanks to Ashish and Dr. Abhijit and Dr. Potanak's lecture is incomparable. I have witnessed so many workshops also. That is not I am going to discuss on that. But the
No, we are not able to see
ICOG, what
your
is the
face.
conducting the program, this type is really commendable. Ashish, Dr. Abhijit, because some people I am saying Dr. Ashok, definitely Dr. Ashok is trying to give a good message to the, and an important thing is all the teachers, what the experienced teacher. Actually, today I have the face brow delivery. Actually, this is not practiced nowadays. Actually, this section is done. But this is every international book, large textbook, vividly that is described. You will see there are many things. But the vaginal delivery is must like that. So thank you, Ashish. Thank you, Dr. Abhijit, for giving me the scope. A few days back, I have also, Dr. Goody was there, another ICOG program certificate for primary hemorrhagia. Thank you, Shobha. Thank you, Prasanna, to all of you.
Job of the teacher is to inspire students.
Yes, sir.
Evolve the techniques, not actually doing the surgery, but inspiring the students. I think that is best done by the
That's true, sir. Actually, learning has become much easier and these days because we used not to get so much platform and so much things. These days, we almost ICOG or even the FOGSI MEDA program, they covers many of the things which are actually quite helpful to the students. So I would like to thank you that as I told this July, so we started program in July 2021. So we have completed 3 years. Yes, sir. We have completed 3 years and we have tried our every effort to come out with the different suggestions to improve us as well. So we would like to thank you, the FOGSI office bearer, the president, the ICOG, everyone. Dr. Ashok, Dr. Ashish has been very supportive in making shape of this program. So we are thankful to all of you, sir. So I'd like to thank you to all the faculties because every time I would like to take the faculties as those who are in expertise. So I'd like to thank Maji sir for having your excellent involvement as well as presentation. I would like to have you in future program as well sometime again. Then we have the students, that is Kurzi Holy Family Hospital students. And I'd like to thank you, Dr. Meena ma'am, and her students, Dr. Rupa and Dr. Deepthi. And I am sure this is going to definitely going to them lots of, even if the first year, they are going to be third and they will give them lots of confidence for future and they are going to be much helpful in their future endeavors. So I'd like to thank you all of our faculties. Ashish sir has been always the supportive for this program. Dr. Maji sir, I have told Shobha madam is always supportive whenever I tell for many things. And madam keeps on giving me or us different suggestion how we can do much better. Then Dr. Pragya Mishra madam, Dr. Prasanna, and finally Hara Prasad sir. That is, I know you that sir you conduct this and that is why me and Ashok sir and Ashish sir discussed now we have to catch Hara Prasad sir and sir was conducting, we know that is on vaginal hysterectomy workshop length and breadth of the country. So I am sure this is going to be lots of helpful for the students, and it will be in record as well as I have told. So the students can go back to in the ICOG website, or some of the students when they will be preparing, they can go just simply in ICOG website. We have recording of the last 3-year program every month. So this is going to be lots of helpful to them. So thank you so much, and we would like to
Great job, great job.
Thank you, Hafiz sir.
Really,
Thank you.
highly appreciable
Thank you,
job.
Shobha ma'am. Thank you, Ashish sir. Thank you so much.
So next,
Recording may be stopped now. Recording, please stop the recording.
yeah, please. So next month on 2nd Sunday in September, we are going to have again assemble with a different topic, different student, and different everything. So we'd like to have to connect each and everyone, and we'd like to have somewhere other involvement again. Thank you so much.
Thank you so much. Thank you.
Thank you.
Thank you.
Bye-bye.